Thanks for everyone for coming. We have a very busy morning and a busy afternoon today, for those of you who are here for morning, obviously. Um, uh, I'm Albert Holt. I'm the Medical Director for Critical Care here at Fairfax and also for the system. We've got about half a dozen or so lectures for you all today to learn more about sepsis. And I was going to start things off by at least giving you some background on how we started this process here. I have no conflicts of interest that I'm aware of. So surviving sepsis. The Surviving Sepsis campaign actually started years ago. This is one of the more recent publications on surviving sepsis, and this is really the foundation for a lot of what we do with regards to sepsis in the system and across the nation. It has been a nationwide initiative around sepsis to improve the mortality that we see with patients with sepsis, as well as the morbidities associated with sepsis. So obviously the goal is around saving lives with people with sepsis. And so we embarked upon a sepsis sprint last year across the system. And I wanted to give you a little background on exactly what a sepsis sprint is and what the sprint process is for those of you who did not participate in the sprint, but were part of the results of what we had done and some of the ongoing activities that we have with regards to sepsis. A sprint is essentially an initiative related to quality improvement. And so part of what I'd like to have you walk away with today is a little bit more understanding of the opportunity to improve care across the system that we did in the sprint, understanding the 90-day objectives that we established and how the sprint was done, understanding the decision support tools that were created as part of this so that you can understand why we created the tools and the tools that are available to you for sepsis, and understanding how performance data on the management of sepsis, how you can interpret it, what to do with it, what the dashboard looks like that we created around sepsis so that you're aware of all the work that was done and how you can utilize the tools and the work that was done. So, sepsis sprints, 90-day sprints. Most of the sprints that we do for sepsis for sprints are around a 90-day clinical effectiveness sprint. And the real goal there is to utilize and leverage some of the resources that we have across the system. So there is Epic Build and informatics that are available to us during this time. There's a quality and clinical effectiveness team that helps us with regards to project management, as well as creating dashboards and the tools that we use. There's finance opportunities that are evaluated as part of this process, and then there's training. So there were a ton of training for, I think for the nurses particularly, that was done last year around the holiday season. It was incredible, and Terry and the rest of the team had led that effort around what was done with regards to sepsis, that over the course of 2 weeks during the holidays last year, 80% of the nurses across the system were trained around what was happening with sepsis, which I think is just amazing. And then from a clinical leadership standpoint, taking a look at what are the best practices and how can we incorporate those into our day-to-day practice and being dynamic about this. And so we put together a multidisciplinary team to do this. And it looks like a duplicative slide. Oh, I see. And so part of the clinical effectiveness sprint timeline is in the first 30 days before the sprint starts. There's a ton of work and planning that goes into the process. And so essentially what we had done was we had taken a look at where the opportunities were with sepsis, what we believe we could accomplish with sepsis, and then we helped to build a framework around what was going to happen across those 90 days so that everyone who was brought into the sepsis sprint was able to be utilized and leveraged so that their time was used appropriately for improving the quality of care on sepsis. And so, as you can see, in the first 30 days, a lot of work was done around what the program was going to be for establishing for sepsis, taking a look at the current literature, what the current practice was across the system, as well as taking a look at where the opportunities were that were identified as part of the analytics process. And we're going to get to that in a second. And then over the course of the next 60 days of the sprint, there was the build around the Epic tools that was built, to build around exactly how this was going to work for the physicians, for the nurses, for the respiratory therapists, for everyone involved in the care of patients with sepsis. How the EICU became involved in what was happening with sepsis so that they were a system-wide support tool for this. And so part of what we took a look at when it came to the analysis around sepsis, and I know this is particularly exciting stuff, but I just want to give you some background on how it came to be. So part of what we take a look at around where the opportunities are we utilize a premier database that has software that takes information across multiple hospitals across the country, that takes a look at these different hospitals. And then they take a look at all the different data points, they take a look at the diagnoses, they have regression algorithms that are part of this, and so essentially what they try to do is they try to compare apples to apples across different hospitals. There are peer group hospitals that are part of this process, so that our peer group hospital is with specific other hospitals of our size, of our resources, of the same kinds of level quality of care that we can provide. And so then they rank where things fall. And so there's about 1,200 hospitals across the country that are part of this database. What you'll see in some of the slides that I'll show will show you where we did when it comes to observe to expected, and I'll explain a little bit of that as to how that relates to how we do. And so when we took a look at where the opportunities were, and one of the things that we're looking at was where were the cost opportunities when it came to sepsis. So how much was it costing us to take care of sepsis patients as it related to other hospitals that were equivalent to us? And so when we took a look at this, this is where the models, the regression models that are created from Premier come into effect, is that we saw that there were probably over $20 million worth of opportunity, and that opportunity meant that we were spending about $20 million more than our peer hospitals when it came to taking care of patients with sepsis. And so from an opportunity standpoint, when it came to the financial opportunity, there was clearly one. When we took a look at mortality, you can see the mortality across the system. So this is how many people died in 1 year time across the system when it came to sepsis. And so part of what we were looking at is where are the mortality opportunities for us, and how can we reduce the mortality that we see with patients across the system with sepsis. One of the other things we took a look at was length of stay. And so you can see, it's kind of a funny slide, but essentially what you see in the blue is the observed length of stay that we had across the system by the system, and then by OE for each operating unit. And so for Fairfax, for Mount Vernon, for Fair Oaks, for Alexandria, for Loudoun, and then all in. And so for the blue section that you see there, that's what we observed. So that's the average number of days that patients were in the hospital when it came to sepsis. In the red is what the projections were with how long they should have been in the hospital. So you can see that we had significant opportunity across the system, over 11 days more than they should have been in the hospital based upon these regression models. And so these are what our goals were in the specific sprint as related to sepsis. We really wanted to make sure that we were identifying patients early and had a workflow that worked to create a fast management tool that people could utilize and leverage. We wanted to make sure that there were Epic tools that were available to everyone to access, so that they can see if there were questions about how to manage patients with sepsis, but it became easy so that there were order sets, there was a flow, and I'm going to show you the flow that was created, and that there's a system of checks and validations on how patients with sepsis went. Again, the goals that we had really were improving patient care, reducing mortality, reducing the cost as demonstrated by the prior analyses, and then have compliance with CMS core measures, because I think everyone knows that compliance with CMS core measures is part of what the CMS has targeted as important as it relates to mortality, morbidity for patients with sepsis, but also as it relates to payment. And some of the tools that we created as part of the sepsis sprint included multiple order sets. So we had suspected sepsis order sets for both rapid response nurses to use when they go to see patients with suspected sepsis, for physicians to use for patients in mid-levels. We also created a transformational order set that's an ED to inpatient order set. That's a little tricky. We have critical care admission order sets for patients with sepsis, as well as non-critical care order sets for patients with sepsis. So depending on what unit a patient was going to, if they were going to an ICU, they would use the critical care order sets. If they were going to intermediate care or some other level of care, you would use non-critical. And we created these things, and other people will talk more about some of the pieces of it that were created as it, so that it was easy to pick what was required to take care of patients, how often to order lactates, what antibiotics were appropriate to be chosen depending on where their suspected infection was, what were the things that needed to happen There were prompts that were created around what specific physical exam tools were required for part of this. We created a huddle checklist, which is a checklist that shows you how you're progressing when it comes to sepsis care, a one page for the first 3 hours, and then for the second 3 hours as it relates to CMS core measures. We created smart phrases so that .sepsis CMS gave you the smart phrase of exactly what you needed to document as part of the CMS core measures. And then we created a way to track for each OU to utilize their huddle checklist, so that you could see in real time, and are still able to see in real time if you're actually utilizing the sepsis huddle checklist. You can see how you're doing when it comes to achieving the CMS core measures when it comes to sepsis. And part of that really is around real-time looks at how you're doing when it comes to sepsis. So you can see in real time so that you're not waiting for Debbie Wilson at the end of the month to let you know how you did when it came to sepsis based upon the screening that she does and the reviews that she does that give you your scorecard at the end of the month. For those of you that haven't seen this, if you just go to the Inova website and type sepsis on the Inova website, you'll see this entire toolkit that was created. So you'll see everything that we created as part of this sepsis sprint that includes the background around the sepsis sprint. It includes the order sets. It includes how each operating unit or each hospital handles sepsis and what their flow is when it comes to who to call, when to involve the EICU, when to involve their sepsis response team. It includes a lot of the EPIC training modules that were created as part of this, so people knew how to track sepsis through EPIC, through the tools that were created, and I'm going to show you some of those. It also includes the background on how we get scored for that. So there's a whole host of things that you have available to you to see on the Inova website that all you have to do is type sepsis and you get the whole toolkit. So I wanted to review with those people who haven't seen this, and for those of you who have, this will be very familiar to you, what was created as part of this. And I want to give credit to Joanne Thompson and the EPIC team. Joanne is no longer with us here, but she put in a ton of effort in creating this, this process within EPIC. And so what we tried to do was we created a flow within EPIC that if you had a patient that was on the sepsis list, that you could track how the patient was doing. So how were you doing in achieving all of the things that you're supposed to be doing? Were you ordering your lactates? Were you giving the fluid that was required? Were you actually giving antibiotics in time? Were you doing the things all according to the process that's created around how this works? And so if a patient became hypotensive, did you provide them with the fluids? Did you then provide them with pressors to actually manage to make sure that their blood pressure came up? Were you doing all the things that was required? And so Joanne created this amazing tool within the system, which basically turned from red to yellow to green in the flow of the patients as you were taking care of patients. So as you can see in this one, there was a patient who had an elevated lactate, elevated white cell count, and screened positive for sepsis. And so you can see that there's a ton of things that need to happen as a result of this. So those things in red are things that need to start happening. You need to start ordering so that you're make sure that this is alerting you to the things that you need to be doing for these patients. And so, so then the process starts. So then a patient will start to get managed. Physicians can order from the panels that we created around what to do with patients, ordering lactates, giving fluids, giving antibiotics, and so the process starts. And you can see as the process continues, the sepsis flow sheet turns from red to yellow to green as you've accomplished the things that you're supposed to be doing with the patients with sepsis. Nurse gives fluids, draws cultures, second lactate comes back still elevated. So what you see here is it reminds you that you haven't ordered antibiotics yet. And so you need to make sure that you get antibiotics ordered as part of this process. Okay, so when the antibiotics get ordered, then it turns yellow. Once the antibiotics are given, it turns green. As you see, once it turns green. And so, and then the patient's blood pressure drops. So you're starting the process of taking care of this patient with sepsis. Blood pressure drops. Okay, now the blood pressure drops. What do you need to do next? Make sure you order your pressors as it relates to this, because you've already given your fluid as part of the first step. Now you give pressors. So then the pressors are started, and then a note is done. And so the note is completed, and that's part of the .sepsis phrase that we created around the note, so that everyone knows all the different components that need to be captured as part of this. So all of this tracked flow was built in Epic so that people would make sure that you understood exactly what the flow is supposed to be, how you were doing, what was needing to be happening next in case there were any questions. And again, the EICU has been the resource for the system when it came to that, so that if there were any questions as it related to what needed to happen with sepsis, that the EICU could be called. And so when we took a look at the things that we wanted to measure when we were done, so we did the sepsis sprint, we created all these tools, we hopefully educated enough people on how to use the tools and continue to educate as appropriate. We've been modifying some of the tools. We've taken a look at what the order sets are and how they should be modified so that people can use them. We'd like feedback from people who are using any of the tools that we created, if we can make them better, because we're happy to do that. But some of the process metrics we started to look at were, what should we be looking at to see that we're achieving the goals that we want to when it comes to patients with sepsis? And so one of the things that we looked at was SIRS screening. And this is an interesting thing because we decided on SIRS screening for patients because what we had done was we had taken a look at the data that we had on patients across the system to see, okay, all of these patients had sepsis, and there was controversy, and it's interesting because this month in the Critical Care Medicine Journal, it kind of came around to exactly what we discovered a year ago when we took a look at this. And that is that when we looked at our data to see how will we best capture patients with sepsis, we used SIRS criteria versus the QSOFA. And the QSOFA is a different measure, a different measurement tool, and it was the one that was being recommended by the Surviving Sepsis Campaign Committee to say QSOFA is probably what should be used. And we decided, well, we took a look at this and we said, well, we know that we capture more of our patients with sepsis using the SIRS criteria than we did with the QSOFA. And curiously enough, in Critical Care Medicine this month, they came out with an article that said that exactly what we had already found was that you narrowed down too many people and you cut out too many people that you could impact by using the QSOFA score, that SIRS was probably a better measure. So we actually did our own internal analysis around this to see what's the best way to screen for patients when it comes to sepsis. And we decided on SIRS over what was recommended based upon our own in-house data. And as it turned out, the Surviving Sepsis Committee eventually caught up to us on that one. So I'm very proud that we actually took a look at our own data when it came to taking a look at what the appropriate screening tool was. And so we took a look at that. We took a look at the calls to the sepsis response nurse to see how many calls were being made. We continued to monitor how many calls are made to the EICU when it comes to sepsis, so that we know in terms of process, are people actively engaged in asking the questions and utilizing the tools that are created? Are people using sepsis order sets? Have they used the SMART phrase when it comes to the sepsis SMART phrase? And then how are we doing when it comes to CMS core measures? So these are all process metrics. And I say they're process metrics because what is the process around what we're doing that hopefully will lead to the outcomes, which really the outcome metrics are around the better care for patients. So what's the mortality? What are some of the costs, readmissions? But essentially we've taken a look at length of stay and mortality as probably the two most important outcomes metrics that we take a look at. And so as part of this, I don't expect you to read this. This is the dashboard that we created as part of this. I'm just going to walk you through the components of it. So this is the dashboard itself in terms of the team and what some of the goals were. This section of the dashboard gives us how we were set up when it came to what our initial results were when it came to observed to expected in terms of mortality and other numbers like that. This part of the dashboard basically lists all of the ongoing activities that we have when it comes to sepsis, so the every other week meetings for how each operating unit is doing and where the opportunities are to improve. This CME is on here. This I'll show you in greater detail. These are some of the outcomes metrics that we measure that I mentioned earlier, and I'll show you those blown up as well as the process metrics. And then each of these different, each of the people that participated in this. And the beauty of the people that have seen this dashboard itself is you can see how each hospital is doing. There are little radio buttons that were created as part of this by the clinical effectiveness team. So you click on whatever your operating unit is, and you can see exactly how your operating unit is doing for these outcomes. So let me give you a little more detail on the process metrics. So The things that we report on, we've just changed this recently. We were reporting on the use of the sepsis order sets and the rest of the order sets. Each operating unit we found has its own processes around what they were doing when it came to some people had created their own order sets, and frankly, I'm happy that everyone is using order sets if they're working. We wanted to make sure that you had at least order sets that were available to you so that if you didn't know what the antibiotic choices were, know what was supposed to happen, that you had that available to you. But so these process metrics themselves, one of the more important metrics, and you'll hear more about this in some of the talks later, around what is able to be accomplished with early intervention around sepsis, is antibiotic administration. So time to antibiotic administration, if people are achieving their antibiotics within the first 3 hours, that's an important metric that we wanted to track across the whole system. And you can see, based upon the colors for the different hospitals, how each hospital is doing. And so this is one of the metrics that we're tracking. The other metric that we're tracking from the standpoint of a process metric, closely as part of the dashboard, are the CMS core measures. And so how are people doing with bundle compliance? And you can see kind of all over the map, and it varies from quarter to quarter. And so part of what we have emphasized as part of what the go-forward quality improvement opportunities are is instead of waiting for the end of the month to find out how you did on this, if you actually utilize the huddle checklists that are part of the sepsis toolkit that you can print up and keep in the shadow chart for patients, you know exactly how you're doing and you know exactly where you are when it comes to doing the CMS core measures. So at the end of the month, you don't say, oh, 25%, not so great. And so we want to make sure that everyone is achieving the core measures appropriately. Outcomes metrics. So the other piece of it that we really wanted to take a look at was how are we doing when it comes to taking care of patients as it relates to our patients, and how do we do comparatively? I can tell you that this looked a lot better a few months ago until Premier did a gigantic regression model and data reset. So essentially how observed to expected works is that if you want to be better than everybody else, your observed should be less than expected when it comes to mortality and length of stay. That would be the red line. And so for us at least, mortality changed significantly when they did a giant reset back in March. And so these lines were closer to here a couple of months ago, and then there was a giant reset done. But you can see the trend has gone back to approximating where we should be when it comes to expected to observed mortality. The blue is the length of stay, and we've been pretty consistent around that. Again, our goal is to be better than what our hospitals are expected to be. And so this shows you the difference. And so as you see the dark orange and the light orange, so the dark orange is showing you what we've observed, and the light orange, so as the gap between those narrow, we can see that we're doing better than we were originally. This is excess length of stay across the system. This little blip here is only 1 month. So as excited as we like to be and saying, oh, look at how great we're doing, that's really only 1 month. The rest of these are by quarter, so we haven't yet finished the whole quarter to see how we're doing when it comes to excess length of stay. But the excess length of stay is in terms of the observed to expected. So if we're expected to have 8 days and we have 10 days across 200 patients, that means that, if I math right, that'd be 400 excess days that we would have here. So that's how these excess days are calculated. And then the mortality, obviously, is do we have more deaths than are predicted? And the deaths aren't individual, per se. When it comes to the calculations, they are collected as a group as part of this model. Thank you. And I just wanted to kind of share with you some of the things that we've accomplished as part of this, all of us collectively. So there's been a 28% reduction in length of stay since 2015. There's been 1,439 patients who've actually been diagnosed. And the mortality that we've seen in terms of reduction in mortality has been 21% since 2016. So we're making progress from where we were before. I think that we continue to have opportunities to make more progress. And so just to let you know, I mean, we have ongoing meetings when it comes to sepsis that Terry chairs every other week for each of the hospitals to participate in, to see how each hospital is doing, what the teams are learning, where there is opportunity to grow and do more. And so I just wanted to share that with you. The meat of how to manage sepsis is coming up next with the rest of the talks, but I wanted to give you background on how we started this process in terms of what we took a look at, how we started to manage patients with sepsis, what were the tools that were created so that you're aware of, if you have questions, how to go and find them. I probably have 2 minutes for questions. We'll have more time at the end. Perfect. Everything was perfectly clear. I love it. All right. Up next. Sure. So the EPIC tool that was created, the questions around the EPIC tool that was created, so no, everyone can see it. Actually, the nurses are the ones that probably utilize it more, but you have to pull patients up through the sepsis list. And so that's how you track within EPIC. So there's a sepsis list, so there's a separate category of patients that you can pull up the sepsis list, and probably Terry can maybe explain it to you better later in the talk, but it's a special list that allows you to track this. So it's not just a physician only. Actually, the people that probably use it more are probably nurses. Hi.
I don't know if it's appropriate to ask now or to ask later, but we work in IMC, and one of the biggest barriers for us has been resistance, I guess, from residents and medical teams concerning the sepsis protocol. So I kind of wanted to bring up, like, again, I don't know if it's appropriate now or appropriate later, but training for our residents and for our medical teams, because we get a lot of like, oh, I don't care about that lactic unless the WBC is over 20, or oh, I don't really care about that SIRS score. Like, so there's a lot of difficulty, at least on IMC, regarding sepsis protocol.
Thank you. So I think that there's more education we need to do across the house staff for sure, absolutely. And I think that that's one of the areas that we're working on for the rest of the year in terms of education opportunities, because we went to nurses, we went to the physicians, the attending physicians. I think we were a little short and shy when it came to the house staff education. And so I think that that's definitely an opportunity for us for this year and moving forward. Thanks.
Great. Good morning, everybody. Thanks for coming. We really appreciate y'all being here. This morning, Dr. Groves and I wanted to start with a case study to kind of bring together and highlight the importance of early detection and sepsis, and we have no conflicts either. This was actually a call I went on a couple months ago that they called me for sepsis to evaluate the patient. JW was a 47-year-old male who received a heart transplant in 2009. He was admitted to the hospital for his 4th episode of acute rejection without any symptoms. It was actually diagnosed on a biopsy. He was admitted to the hospital for plasmapheresis treatment, thymoglobulin infusion, and went to IR that day, had a Quentin cath placed, had his first pheresis treatment without any apparent reaction or complications, was admitted to the tele floor for the thymoglobulin infusion, and 15 minutes after the infusion started, he had a reaction, shaking, chills. They stopped the infusion. In a little while, his symptoms relieved themselves and had no problems. A couple hours later, he developed fever, chills, hypotension, and vomiting and back pain. At that time, a call was made to the covering doctor who was on, and a 250 cc bolus of normal saline was given, but no real results, no change in the blood pressure. Patient continued to be hypotensive with a MAP of less than 60. Again, the MD was called. At this time, no orders were given. It was communicated at that time that the MD did not know the patient he was just covering, did not feel comfortable with more fluids, was concerned with fluid overload. The nurse's note read, patient was asymptomatic, and the patient states he feels better. Of note, the SIRS screen was done at the beginning of the shift. It was 0. It was not repeated at the time of the patient's conditions changed, when his condition changed. Nothing else was done that shift. The next nurse came in. At that time, the patient had been hypotensive for over 7 hours, with MAPs as low as 47 in the 50s, but still looked fine, felt fine. The day nurse or the next nurse called the transplant MD on call, Another 250 cc's of saline was given, and then she called us. She called sepsis response team, rapid response, to come to the bedside and evaluate him. And at that time, his SIR score was 4. Labs were done showing a creatinine doubling in less than 12 hours. It was initially 1.5, it went up to 3, probably from the hypoperfusion to his kidneys from the low blood pressure. His labs also showed a worsening leukocytosis. Initially he was 5, and then he went up to 20. His lactate was 2.5. So after my initial evaluation, I called MCCS here at Fairfax, the critical care team, to come to the bedside and see him. We immediately started a 500 cc bolus of saline, drew blood cultures, and then we had to transfer him to the CCU for a second central line insertion for infusion of norepinephrine. We were able to start his antibiotics then within probably 1 to 2 hours, and he continued those antibiotics for the full course. He did have to stay in the CCU for 2 days, one of those days needing the norepinephrine infusion. His baseline kidney function did return in about 4 days. He was lucky for that and needed no interventions for that. But I think we can identify several things that could have been done differently, should have been done differently in this case. One of the easiest things for bedside would have been if we rescored his SIRS at the time of his condition change. At that time, had we rescored his SIRS, he would have been elevated. It would have prompted you to ask those next 2 questions, which would have then triggered a banner to come up to call either the EICU or here at Fairfax 5532 or the sepsis response at the other hospitals. If we had been called, we could have gotten to the bedside earlier and possibly, done the lactate earlier, done the blood cultures earlier, and started antibiotics earlier. The other thing is the patient was really unstable. Even though he looked good, his MAPs were less than 60 for hours. A rapid response should have been called to come to the bedside and actually start treating the patient right away. So we would have been able to get there and get the lactate and everything going. There's no way to tell if we could have prevented his transfer to the ICU, prevented that second central line insertion, or the need for Levophed, but it's possible with the earlier intervention, we could have prevented his acute kidney injury. So for me, if there's anything you guys take away from all of this today, is if you're unsure, call 5532 here at Fairfax, call EICU for all the operating units. For us, it's a simple look in the chart. It's a simple, look at the patient. Oh, you're already being covered. Oh, no, we need to go see this person. It's very easy on Epic for us to tell what we need to do. We're here 24/7. EICU's there 24/7. There's no reason you should not get any pushback when you call us. And, speaking to the IMC thing, you can call us. We have no problem calling doctors and telling them to order things. So we're just a phone call away. So, if you're having pushback from a house officer, give us a call and we'll come look at the patient. And that's it. Does anybody have any questions for me about that? No? Okay. I'll turn it over to Saleha or Dr. Groves.
Good job. All right, thank you. Okay, so in the next few slides, we're going to talk about some learning objectives. Sepsis is a medical emergency. Screening sepsis saves lives. And early intervention, including IV fluids, assessment, lactic acid, cultures, and antibiotics, improves mortality. So sepsis is a life-threatening condition that arises when the body's response to infection injures its own tissues and organs. Patients with organ dysfunction, which is defined as a SOFA score over 2, have an in-hospital mortality of 10%. The table at the bottom shows the SOFA variables, which include P to F ratio, GCS score, MAP, vasopressors, creatinine, urine output, bilirubin, and platelet count. Patients with sepsis, septic shock, which is defined as requiring vasopressors and a lactic acid over 2, in spite of fluid resuscitation, have an in-hospital mortality of over 40%. Screening for maternal sepsis is slightly different due to the changes that are normal in the pregnant population. In these patients, they're higher risk for sepsis if their heart rate's over 110, respiratory rates over 24, white blood cell count of over 15, fetal heart rate of over 160, and a glucose of over 140. Okay, so this is a study that looked at if screening improves mortality and decreases cost. This was a study done out of a Houston hospital, and the hospital had 180 beds in the hospital. So what they did was they screened all inpatients, including ED, ICU patients, and they screened them at 12-hour intervals, and if there was any change in clinical status of the patient. If the screen was positive, the nurse notified a second responder that intervened within an hour. So the picture, how do you get the pointer? Oh, thanks. Okay, got it, thank you. So this picture here shows the screenshot that they were using. They were using like an Epic system at the time, EHR. And this shows the interventions that were done within an hour. So they screened, it's kind of small here, but in 2009 they screened 3,000 patients. In 2010 they screened 8,000 patients. And in 2011 they screened almost 10,000. And what they found was that screening improved mortality and decreased cost. So the sepsis-associated inpatient deaths were 21% after screening versus 29% before screening. And the cost to CMS for their sepsis-associated stays were $6.5 million less after screening as compared to before. So now we'll talk about interventions, including IV fluids, frequent assessments, a goal map of over 65, lactate, cultures, and antibiotics. The Surviving Sepsis campaign recommends administering 30 cc's per kilo of IV fluid within 3 hours for sepsis-induced hypotension. They got this number based on these 3 studies that were published out of the New England Journal that compared early goal-directed therapy to usual care. And on average, the early goal-directed therapy patients received about 30 cc's per kilo of fluid. They also recommend frequent assessments, including measuring heart rate, blood pressure, temperature, looking for assessment of inadequate tissue perfusion, the skin, kidneys, and brain, to perform sequential evaluation of hemodynamics status, including dynamic variables over static variables, and to perform an echo if needed to evaluate the type of shock. This was a study it was a meta-analysis that looked at the predictive value of CVP for fluid responsiveness. They had 51 studies, including 1,000 patient data sets, and they lumped these groups to a CVP of less than 8, 8 to 12, and more than 12. And what they found was that the positive predictive value and the negative predictive value of these numbers were relatively low, between 40 and 60%. What they determined was that CVP has limited utility in defining fluid responsiveness. This picture shows the responders in blue versus the non-responders in pink. And if they were less than 8, they were more likely to be fluid responders, but this was not significant. If their CVP was between 8 and 12, it was 50-50. And if they were more than 12, they were more likely to be responders, but this was not significant too. So the next thing that we're going to discuss is passive leg raising. So passive leg raising is defined as increasing the fluid, the blood in the legs to the heart, roughly 200 to 300 cc's of fluid. And this is how you do it. So for step 1, you check that the trunk is at least at a 45-degree angle. Step 2, you use the bed adjustment and avoid touching the patient. Step 3, assess the passive leg response effects by directly measuring cardiac output, using a real-time measurement of cardiac output. And step 5, reassess the cardiac output in the semi-recumbent position. and administer fluids if they are responders. If their cardiac output increases by more than 10%, then they're defined as being responder to fluids. So this is a meta-analysis that evaluated the predictive value of passive leg raise for fluid responsiveness. It included 21 studies with 995 fluid challenges. And what they found was that passive leg raise can predict fluid responsiveness with a sensitivity of 85% and a specificity of 91%. So this study looked at the goal map, and they tried to define if a map of 80 to 85 was better than a map of 65 to 70. It was a multi-center open label trial, and this table shows the demographics of the patients included in this study. And between the two groups, the demographics were unchanged. What they found was that the mortality was the same if you use a goal map of 65 to 70 versus a goal map of 80 to 85 at 28 days and at 90 days. The only difference was that if you had a goal map of 80 to 85, you had a higher rate of atrial fibrillation. And lactic acid. So lactate is produced, it's a balance between production and consumption. It's produced by muscles, skin, brain, intestine, and red blood cells, and it's metabolized by the liver and the kidney and increased with tissue hypoxia due to a decrease in tissue perfusion. So this was a study that looked at lactic elevation and hypotension to see if it predicted the clinical outcome. So they looked at what turned out to be 23,000 observations with a serum lactate. And what they found, and I used these numbers here. So if the patient was hypotensive, let's see, 5,000 patients were hypotensive with a lactic acid of less than 2. 3,000 were hypotensive with a lactic acid of 2 to 3. Roughly 2,000 were hypotensive with a lactic acid between 3 and 4, and 5,000 patients were hypotensive with a lactic acid of more than 4. So as your lactic acid went up, your rate of in-hospital mortality increased. So the odds ratio of dying in the hospital, if your lactic acid was more than 4 and you were hypotensive, was 2.1 as compared to patients that were hypotensive and had a lactic acid of less than 2. So what they found was that if you have an elevated lactic acid and hypotension, it's highly associated with in-hospital mortality. Patients that had a lactic acid of over 4 and were hypotensive had a 44% risk of in-hospital mortality, as compared to if you were not hypotensive and your lactic acid wasn't more than 4, your hospital mortality was 23%. So this was the study that determined if resuscitation directed at decreasing lactic acid improved mortality. It was a multi-center open label trial that included ICU patients with a lactic acid of more than 3. And they had 2 groups. One group was the lactate group, which they directed treatment at decreasing the lactic acid, with a goal of decreasing the lactate by more than 20% every 2 hours for the first 8 hours. In the control group, the treatment team had no knowledge of the lactate number, except for the admission value. And this table shows that the baseline characteristics of both sets of patients were the same. What they found was that the patients that they were guided by lactic treatment had an improved mortality. And after adjusting for risk factors, the lactate group had a significant reduction in the risk of hospital death. They did find that there was a significant difference between the 2 groups in the IV fluids administered, and the patients in the lactic group did receive more fluids. Cultures. So this study looked at if antibiotics prior to cultures affected culture growth. It was a prospective head-to-head comparison of blood culture media types, and they collected data on 9,000 cultures and looked at the impact of prior antibiotic exposure on bacterial recovery. The table's a little bit busy because I think they were trying to sell one blood culture media over another. But the point is that they found that administering antibiotics prior to obtaining cultures decreases the likelihood of bacterial growth. So this study looked at if delays in antibiotic therapy affected in-hospital mortality. It was a retrospective cohort study that included 2,000 patients, or 2,700 patients with septic shock. With these patients, roughly 2/3 of them had infections in their lungs and in their abdomen. What they found was delayed antibiotics decreases survival. Each hour of delay is associated with a decrease in survival of 7.6%. And administering antibiotics was the single strongest predictor of outcome. So what this picture shows is that this is the time of onset of hypotension and when they received antibiotics. So if you give someone antibiotics within the first hour, their survival fraction is over 80%. The longer that you wait to give them antibiotics, their survival fraction decreases. And then bundles. This was a study that looked at, that tried to evaluate if standardized evaluation and treatment of septic patients improves mortality. It was a prospective, observational, global study that included almost 2,000 patient records from 600 hospitals in 62 countries. And at the time, their bundle included at 3 hours lactic acid, blood cultures, antibiotics, IV fluids, and then at 6 hours, repeat lactate, vasopressors, CVP, and then SVO2. So what they found was that standardized evaluation and treatment does improve mortality, although the compliance was low. So at the compliance of the 3-hour bundle globally was 19%. Of those patients, though, the mortality was improved, 20% versus 31%. And those compliant with the 6-hour bundle was only 36% of patients. But again, of those that were compliant, their mortality was improved from 22 to 32%. So in summary, sepsis is a medical emergency. Screening does save lives, and early intervention improves mortality. Any questions?
You know how long they kept the leg up before checking the cardiac output?
I don't. I'd have to go back. I'll let you know. Cardiac output.
Well, we have seen a change in blood pressure
Yeah.
with just doing that. We do that. That does it at the bedside all the time.
Yeah, so that being said, we actually do look at the blood pressure, but all these studies just looked at cardiac output.
Just to answer, the straight leg raise has been done mostly with looking into the cardiac output measurements. That is the best way to do it. There are few studies which look only at MAP, and when you look into sensitivity and specificity is lower. But if you don't have the cardiac output measurement, it's probably the best you can do. So, but it's not as good. The area under the curve is lower. So the timing people looked extensively into that. Traditionally, it has been advocated between 45 and 130, so 45 and 90 seconds. It turns out, just recently published, it's probably within 30 seconds you have the answer.
Thank you.
Just this week, our infectious disease doctor was questioning with our ED team why urine cultures hadn't been obtained before starting antibiotics. And I was looking at some of the guidelines, and there's kind of a rough suggestion of not delaying antibiotics by more than 45 minutes. Based on the research you looked at, what would you advise in that situation? You know, every hour of delay increases mortality, and to what extent should you make an effort to get cultures before starting antibiotics?
That's a good question. You know, I think you just do the best you can. You know, ideally you would get the cultures before the antibiotics, but you don't want mortality to decrease as a result. So, you know, I would just recommend doing the best you can to get both. And if you find you're waiting too long, then just give the antibiotics.
You might get more in the next talk from Seth and
Oh, yeah.
David, who are going to talk to you about antimicrobial. So just figured to
Thank you.
mention that.
One more question, if you don't mind. 1 second. The only problem we face in emergency room when we have a high lactate and hypotension in a cardiac patient, and they still go ahead and with the fluid bolus. And this is where we have a little problem with the emergency room. Like, it's not really a septic picture, but so, I mean, where do you draw the line? I mean, is there, because you said you save on cost, but then there's a lot of patient who's getting the fluid who doesn't need it just because of high lactate and hypotension.
Yeah, you know, I think you bring up a good point, and I suspect that the surviving sepsis guideline recommendations may change in the future with regards to the fluids, but as of right now, that's what's recommended. But I'm with you. I totally understand.
And for those, I didn't do introductions, and I apologize. For those of you who don't know Dr. Grove, she's one of our MCCS intensivists, as well as the ICU medical director, and Dee Dee is one of the more experienced ICU nurses and a rapid response nurse here as well. And I just want to thank and emphasize a couple of the points that they made is that the clinical bedside assessment that Dee Dee mentions is really important as part of what nurses and clinicians are doing at the bedside. And there are people available to you if you have questions. And if you're actually finding that patients' conditions are changing, then utilize the tools that you have available, like redo the SIRS screening and other things, and reach out if you have questions. I think it's really important to understand that there are people out there who can help you with the questions that you have about what to do at the bedside. Each OU has sepsis response nurses and teams of some sort or another that are able to help you. And I think Dr. Gross did a good explanation of why lactate is important. I think it's been very controversial about why we even bother measuring lactates. I think that we see that the mortality numbers that she showed are important when it comes to why that's significant for us. And we may not love it. We may not love being restricted, have the 6-hour restrictions and making sure that we're doing all these things in a certain time frame. But there is some clinical evidence on why we're actually doing that. And I think that the 2018 guidelines, as she suggested, is probably going to change around the fluid management of patients. Up next, we have Svet Jerkovic, who's one of our physicians, who is one of our critical care physicians who happens to be triple boarded, medicine, critical care, and infectious disease. Is that correct? And then David Allen, one of our ID pharmacists, here to talk about antimicrobial therapy and sepsis. So they can talk to you about approaches to take, and John probably to answer some of your questions around this as well.
All right, thank you for the introduction, Dr. Holtz, and I think Dr. Jorgovich and I are excited to talk about what we can all agree is probably the most important thing for improving our patients' survival once we have figured out they are septic, which is the antibiotic therapy. So our objectives today are to evaluate the resistance and possible choices for antibiotics, and empirically what kind of antibiotics we should be using for the site of infection, and then Dr. Jorgovich will be talking about de-escalation and the use of procalcitonin as well as some adjuncts. So, as was mentioned earlier by Dr. Groves, this is certainly what we usually think of as the 7% reduction in survival for every hour of delay in antibiotics. So really, I'm not going to dwell on this, but the time to administration really should not be delayed for almost any reason. What you had mentioned with the drawing cultures first, it's, any effort that can be made to get the cultures first should be taken, but then we really shouldn't be delaying antibiotics for any significant period of time for that reason. And so this is a study done in 2009, back when we were not quite as good at treating sepsis. And you can see even with appropriate antibiotics for septic shock, it was about a 50% mortality or survival rates. But if you look at if they got inappropriate antibiotics initially, 10% survival rate. So we really want to be able to provide a regimen that we think is going to be covering the patient adequately up front, and then we can de-escalate from there as we get more information. And then in this study, they looked at combination therapy versus monotherapy for patients specifically in septic shock. And you can see the monotherapy pretty much did worse than the combination therapy in all the groups that they looked at. Now, for this study, it was specifically septic shock, so it was very high-risk patients that they were looking at here, where they recommended combination therapy across the board with about a 10% improvement in mortality with combination compared to monotherapy. Now, more recently in 2015, there was this review which looked at, as you can see, many studies in these forest plots looking at combination therapy versus monotherapy. And over here on the left is the highest risk groups or studies, so mortality greater than 25%. And down here, you can see combination therapy ended up doing better. That's where they all lean towards the left, where combination therapy was better. But then if you looked at studies with a lower level or more moderate level of mortality, you can see it actually didn't make a difference if you did combination therapy or monotherapy. And then lastly, if you looked at patients who were not very high risk with a mortality less than 15%, the monotherapy group actually did better. So really it should be thought of as, how high risk is this patient? Is this patient in septic shock? Then really I want to be putting on multiple antibiotics to make sure I'm covering as best as I possibly can, depending on what the source is. Or is this more of a sepsis that's, from a cellulitis and they just have a little bit of a fever or something and isn't really that severe at the moment? You can probably get away with more of a monotherapy type of approach. And so the guidelines do reflect this. Here is the Surviving Sepsis Guidelines excerpt, where they do recommend empiric combination therapy up front for initial management of specifically septic shock. But then they do recommend de-escalation with discontinuation within the first 5 days or earlier, depending on how the patient is doing and what kind of additional factors are found. And they do not recommend combination therapy for less serious infections without septic shock. So up front, they acknowledge that you probably do not need to be that aggressive if they're not in shock. And then all the recommendations that we're going to be talking about shortly are going to be based off of our local resistance rates, which is what guidelines generally recommend. This is a picture of our antibiogram. This is the gram-negative one for Fairfax. And you can see, I'm going to show you where you can find this on a Novanet, but you can see that all of our most common pathogens are up here, and all of the most common drugs that we test are here. And if you just line them up, you can see what our resistance rate would be. So for E. coli, for instance, if you were to use ceftriaxone for UTI, it would be about 89% chance that you would be covering that, as opposed to if you use something like a quinolone, it would be more like 70% chance of covering it. And then this is a picture of our sepsis antibiotic order set that we put together as a result of this sprint. Really, we made edits to a previous order set, just looking at our more current resistance rates. And biggest change probably was switching a lot of quinolones over to aminoglycosides, just because they do provide a much better add-on agent when we are concerned about Pseudomonas or some of our other gram-negatives. And we're just going to go through section by section. I'm going to spend a little more time on this one, the community-acquired pneumonia versus hospital or ventilator-associated pneumonia, since a lot of these drugs are going to be recurring. So for community-acquired pneumonia, we do recommend the usual ceftriaxone plus azithromycin, and those are automatically selected there. And then you can have the option of adding on-vanc if you feel that there's someone that is high risk of MRSA. Most of the time, we don't usually think of that for community-acquired pneumonia, but if, say, it's influenza season and they've had a recent influenza infection, that would be a risk factor for it being MRSA potentially as a super infection, or let's say they're already NARS swab negative and they're pretty severe, it would be reasonable to add this on. And then for severe allergies only, we do have Levaquin as a switch from ceftriaxone for these patients. And you can see down here for the hospital and ventilator associated, we have a lot more options. So up front, we acknowledge that everyone here seems to like their vancomycin, so we do put that as our first line option. It's pretty much equal to cefepime for the vast majority of the bugs that they cover, so we don't really have a huge preference there. The Zosyn does actually seem to have less of a risk of causing C. diff than cefepime, so that's one good reason to use that. But then there is a lot of literature coming out that the combination of vancomycin have a worsening of AKI rates compared to cefepime, so that's kind of one thing to weigh a little bit when thinking about this. But then we put cefepime largely for mild to moderate beta-lactam allergies to give you that option there, since the rate of cross-reactivity with a penicillin allergy with a cephalosporin is really only about 2% in the most robust literature that's currently out there. And then we have aztreonam as an option specifically for the severe beta-lactam allergy patients, since that does not really have any chance of cross-reactivity for the most part, with some very rare exceptions. And then meropenem for anyone with a history of MDR or ESBL organisms. Meropenem is really not any better for Pseudomonas. It's actually a little bit worse for Pseudomonas rates. But then if you have a history of an E. coli that's an ESBL producer, for instance, it's going to be significantly better. So you really should have some kind of history driving if you're going to use meropenem for a patient. And then something else I want to mention is the gentamicin is the add-on for all of these, is a plus or minus. So you have the option of adding that on. The direction in the order set is generally if they are in septic shock, if they have an elevated lactate above 4, then we would recommend adding the gentamicin, whereas if they're not really in shock, the gentamicin, it may provide you better coverage, and if it's someone with a really long history of highly resistant organisms, I would consider giving it even if they're not in shock, but generally I would only give it for shock for the most part. And then one other thing I want to mention, the aztreonam, I just want to make sure everyone's aware, really only providing gram-negative coverage there, and it's really not even as good of gram-negative coverage as our other beta-lactam agents from all the other regimens. So this really should only be done for patients who are anaphylactic. That's why it's really just severe allergies. And we often remove vanc in these patients when we get them NAIR swab negative for MRSA. In the case of aztreonam, you probably don't want to do that because you're going to be losing all of your gram-positive coverage, not just the MRSA in this case. So unless you actually have a culture saying that you have a gram-negative, I would probably keep the vanc on a little longer in these cases. And then if we want to look at UTI, we separated it out into community-acquired UTI and hospital-acquired or catheter-related UTIs. So the community-acquired, we actually just put ceftriaxone as our first-line agent because E. coli is the vast majority of these cases, and our sensitivities for E. coli for ceftriaxone are 89% sensitive, as opposed to like cefepime or zosyn, which are really, maybe 2% better. So it's really quite negligible. And I looked, I actually looked a little deeper into our data for UTIs and found that for other bugs like Pseudomonas that we would be potentially concerned about, it was really only our patients that were coming to us from nursing homes or with a catheter already that were at a higher risk of these more resistant pathogens. So that's why we separated out and did cefepime up front in this case. And then the vancomycin as an option for particularly the catheter related, since you are more concerned about gram-positives in that case. Still largely gram-negative, but it certainly is possible to have an MRSA potentially for a catheter-associated one. And then gentamicin as an add-on option for these. And certainly MDR option for these UTIs, particularly for these patients coming from nursing homes. And then meningitis. You can see our normal community-acquired meningitis kind of coverage of ceftriaxone and vanc is our first line. And then aztreonam and vanc as our alternative, which you better have a very, very severe allergy for me to want to recommend aztreonam for meningitis, honestly, since you're losing your double coverage of your strep pneumo in this case, since really you're only covering that with vanc in this case. You could also consider a quinolone as well, since they do penetrate pretty well, but there's very little literature out there on using them in practice. And then for immunocompromised or really anyone over 50, you can see that we add in the ampicillin for listeria coverage here. And we do add in a mild to moderate beta-lactam allergy with meropenem, since you can't have the ampicillin in that case, but the meropenem is also a very low cross-reactive of about 1%. And then for our severe allergies, we have aztreonam with Bactrim for our listeria coverage, plus vancomycin. And now skin and soft tissue, this one I admit is a little more complex than we would prefer, and honestly a little broader than we also would prefer, but unfortunately CMS is very specific on what they consider to be adequate coverage or not for sepsis. So originally we only had vancomycin as our initial coverage, But unfortunately, vanc monotherapy would be a fallout for CMS. So we did add ceftriaxone for broad coverage, and it is certainly reasonable in certain cases to have very broad coverage for skin and soft tissue infection. There's a wide range of presentations here, but really the thing to know is if it's purulent, you probably should have the vanc. That's going to be more MRSA associated. If it's non-purulent, it's more likely to be a strep. So honestly, you could probably get away with something like cefazolin, or in this case, you could do just the ceftriaxone. It would be a little easier dosing-wise, but honestly, my personal preference is cefazolin or something of that sort, since it would be very narrow. But really, upfront, this certainly makes sense, but then you can definitely narrow. But then if you have risk factors such as a diabetic foot or something, you certainly need to be much broader and consider anaerobes and more resistant gram-negatives. Hence why we have like cefepime, estrinum, and meropenem down here as options as well for, actually this wasn't for allergy, I think this was for like diabetic foot, it says in the order set. And then necrotizing fasciitis is basically completely taking out the lower severity and going straight to Zosyn for broad coverage with vanc, and then clindamycin as well for the potential toxin production. And then the last one, the unknown source. This is really the same exact guidance as the hospital-acquired pneumonia one here, just trying to broadly cover for all of our most likely gram-negative organisms as well as MRSA. And then it wouldn't be a pharmacist talking about sepsis if I didn't, plug some vanc kinetics. So I don't want to mention vancomycin loading because I feel like there's a lot of confusion out there as to when we should or shouldn't load, and then what the risks versus benefits of loading are. There's actually surprisingly little research out there as to what the benefits versus risks of vancomycin loading is, even though it is a pretty widely accepted practice in a lot of places. But I'm going to use a 100 kilogram patient as my example here, and say we just gave 1 gram to him. His peak would be about 14 in this case, which is lower than even our goal trough is, and that's as a peak. So if we take that up to 15 mg per kg, give him 1.5, it would be a peak of 21. That's certainly better. But then if you think about the fact that you're also pumping tons of fluids in this person, you're really kind of altering their normal volume of distribution. So normally we say 0.7 is what me or you would have. So if you gave me vanc, that would be my response. But if you're giving me 4 or 3 liters of fluid, then really that 15 mg per kg goes down to a peak of 15. And if you did a full load of 25 mg per kg, then you would get a peak of around 25, which for comparison's sake, let's say you do a full course and then you draw a peak, which I know we don't do very often. If you drew a peak in a normal patient, it would be more like 35. So even at 25 mg per kg, which is a pretty big dose, you're not really getting above normal kind of peaks by any means. And we cap it at 2 grams anyway. And the guidelines do actually recommend using 25 to 30 as your loading dose, which here we generally do 20 to 25. So I would definitely err on the side of that 25 personally, especially if they're in severe like septic shock or something. And then this is my last slide here, looking at vancomycin toxicity when you load. So first, the study group by Rosini and colleagues had a very small study looking at nephrotoxicity just at 15 mg per kg versus 30 mg per kg for first doses. They didn't see any difference, 5.1 compared to 4% rate of toxicity. But then if you look, they looked a year later at a much larger group, and they looked at people who got less than 20 mg per kg or more than 20 mg per kg as their first loading dose. And 25 was the average for the high dose for the people that really got loads, and 16 was the average for people who didn't really get loads. And you can see a doubling in nephrotoxicity for the patients who did not get the loads. So loading with vancomycin likely does not cause nephrotoxicity, and if it's the agent that's covering, you're actually likely improving your rate of toxicity. I had another slide that showed kind of graphically how it works, but basically it's 2 hours to get effective concentrations if you load, as opposed to up to 72 hours until you really get our goal concentrations if you don't load, if it's someone who's in AKI. If you're doing like a Q8 dosing, it's going to be much faster, but it can be a pretty significant difference in how long it takes to get to goal in this kind of case. Right, Dr. Jurgovich? Oh. So that, unfortunately, there's really very little published as far as outcomes. What we do know is if you get to appropriate it's really AUCs of about 400, not necessarily levels per se, early, that there are outcome differences, but they don't really specifically look at just loads in that case. So no, there's not really much out there as far as outcomes.
Yeah, that was a fancy one. Yeah. So I'll be talking about two things. I'm Svet Jurkovic. I'm from critical care. I'll be talking about procalcitonin and the use in sepsis and a little bit about it, and then I'll talk about very much debated Paul Merrick's study about vitamin C, thiamine, and steroids. So it's only me between you and the break. So let's accelerate. So. What is procalcitonin? So procalcitonin is really a precursor of the calcitonin. Calcitonin is something that brings your calcium down. Procalcitonin is secreted by two kind of cells. So it's parafollicular cells of the thyroid gland, which it's not that important here, but it's also secreted from neuroendocrine cells of the lung and intestine. So interestingly enough, it's not secreted by your white cells or any kind of immune cells. So it's, that is where it comes from. So the later, this neuroendocrine here, cells secreted in sepsis. It correlates with many other inflammatory molecules like TNF-alpha, interleukins 1, 6, and so on, and it increases rapidly about to 400 times in bacterial infections. So that is all between human and animal data. Peaks between 12 and 24 hours. Remember that it increases between 2 and 4. So if you draw it very early on, might be still negative. So half-life, it's between, it's around 30 hours. So why are we talking about this calcium thing here? We said it increases in infection, bacterial infection in particular. So it would make perfect sense to use it if you suspect bacterial versus viral infection, because you say, okay, patient has a runny nose and is coughing a little bit, and who knows, does he have a bacterial or viral infection? Based on the first slide, yes. Now, the problem there is that in critical care, no one comes, or rarely we see a clear-cut patient. We have patients who have many other conditions, and it can increase with severe trauma, with burns, multi-organ failure, quote unquote. That is one study. All of our patients have multi-organ failure in the end. Major surgery, pancreatitis, obviously the thyroid cancer, and then with renal failure. Now, as you see, a lot of reasons to have false positives. So this is, now this is, and it doesn't show entirely, this is the false negatives, which is also a possibility. So the procalcitonin in false negative obviously is going to be low if the PCT, so procalcitonin is low, but patient has an infection. What are those conditions? So if the infection is localized, let's say parapneumonic abscess or just an abscess, if it's done too early, if you have gram-positive bacteria, it can be negative. And they looked into this in detail in some studies and showed that in particular with Staph aureus, it can be low. It's not necessarily low. It can be high or low, but they are false negatives with Staph aureus. And then there is something fancy because he talked of volume of distribution. I'll talk about hook effect. So extremely high procalcitonin, very, very high. What can happen is that in a test where you would need the capture antibody and then this detection antibody to react here, this detection antibody can be, could be blocked if the levels are exceedingly high. So it's called hook effect, yeah. What you do in this, obviously, if you're tremendously smart and so on, you ask the lab to dilute it, because then you get less of antibodies per unit and you would be able to detect it. Now, this was the background. So, where has procalcitonin been best studied? There are two sets of patients, let's put it this way. Really, the best studied, it was starting antibiotics in suspected respiratory infections, and that was exactly what we were talking about, to distinguish viral from bacterial infection. And that is where the most of the studies were done. It's there are a lot of observational studies which are worth whatever they are worth, but there are more than 10 randomized trials published. The cutoffs are usually between around 0.25, give or take. And in most of these studies, obviously, in order to get patients enrolled at all, clinicians were allowed to overrule the procalcitonin value. So, because there is possibility for having false positives and false negatives, the trials were done if you think avoiding or not giving antibiotics would be harmful to your patients, you're allowed to give them, obviously, because someone has very high suspicion, you cannot stop it just based on procalcitonin. So this is how most of these trials were designed. When you look into the, several of these studies and meta-analysis, there was a reduction on antibiotic use, and there was no increase in bad outcomes. So it appears to be at least in respiratory infections, it might be very reasonable to use it, in conjunction with your clinical judgment, So procalcitonin in conjunction with your clinical judgment would appear, at least from here, to allow you to stop antibiotics sooner. So it's useful. Now, what about the septic shock patients? So it's the conclusions, and you remember that we said there is a lot of false positives. So the conclusions are not so clear. However, it's even more debatable because there are multiple studies. Thresholds for stopping antibiotics were very much variable. Some used the percentage of drop of initial procalcitonin. So if you had initially 20 and you went to 5, was equivalent starting with 10 and going to 2.5, So percentage-wise, percentage drop. Or some of them used absolute number, less than 0.5. There is the biggest trial which used actually both. And they showed that in this trial, this is the biggest one, SEPS trial, showed that more than 1,500 patients, they decreased use of antibiotics. So it's about 5 versus 7 days. More interesting, or thought-provoking or intriguing is that numerical numbers show that people who were randomized to procalcitonin had lower mortality. And you can easily think that overuse of antibiotics is not good for you. That would be the thing, but this is just obviously hypothesis generating and not conclusive. So before we move to Paul Merrick and different vitamins, my take on procalcitonin, we do use it occasionally, not regularly. It's not in our protocols. It's not by no means, but it might help you. It's almost procalcitonin can hold your hand in stopping or continuing antibiotics. So if you see initially very high number, and we just have a patient in one of our ICU beds, completely unknown fever, unknown origin. The fact that her procalcitonin was 40 told me that I have to give her antibiotics, although I think she might have a drug reaction. It's just too high, and it's the combination of everything. But it's in a context, it might be helpful. It shouldn't be, obviously, by no means, like nothing else in infected patients, should be a sole parameter. Now, we'll talk a little bit about vitamin C, thiamine, hydrocortisone in severe septic shock. So this is your vitamin C and your thiamine. And then steroids. So remember, steroids, I wanted to put bodybuilder here for steroids, but then I said it's not exactly the same steroid, so let's move on. Yeah, so what did Paul Merrick, so the question of this study was the following. Can we find, the guy started, he was here just about 6 months ago or so in March. So he is a very charming and brilliant and smart, very strongly opinionated guy. Paul Merrick, never argue with Paul Merrick. That being said, he said, is there an intervention in patients with septic shock that can be used in poor resource countries, in Central African Republic or Congo or whatever, that doesn't cost a lot and can potentially save lives? Because a lot of stuff that we do is high-end, tremendously expensive. So there is evidence from trauma literature and some burn injury literature that vitamin C might be helpful. There is evidence that in septic shock, there is about, give or take, around 50% of patients have relative thiamine deficiency, even though they're not alcoholics or malnourished or anything like that, but just relative thiamine deficiency. And then there is, forever going saga of how much steroids help in septic shock, but there is consensus that it's not unreasonable to use them in refractory shock, I would say. So his question was whether the combination of all of this, vitamin C, thiamine, hydrocortisone, in addition to standard of care, so antibiotic, everything that Soleil already explained, improve outcomes in severe septic shock. So there are many reasons to think that pharmacologic, actually Paul Merrick's first degree was, he's a pharmacist, so many cellular level kind of evidence that combination might be synergistic. So that is why he put this all together. So whether all this can improve outcome in patients with septic shock and high procalcitonin, so more than 2. The study, just before we go any further, the study was done, the design was pre and post. He went through 1 year when they did not use it, compared the patient to the year when they started to use it, and he matched them. So he matched them. You'll see in a second, he matched, actually that is here, he matched them very, very well. So if you look into this, this is controls, pre, and this is intervention year. Numbers of patients are small. Yeah, it's about 47 patients, I want to say. 47 here, 47 here. I would like to, it looks here, everything looks very, very, I mean, yes, some differences, but for the most part, well matched. I would want to turn your attention to one number, this number here. So just memorize this number for a millisecond, yeah? 22 or 46% of patients in control arm are on pressors, 46%. So just memorize that and bear with me for a second. When you put this Apache 2 into your calculator and calculate mortality, it turns out to be slightly more than this. So from here, you say, everything looks okay-ish, yeah, so far. Then you come to this one and you look into outcomes. So, I mean, treatment group, this is phenomenal. If this is true, this is, better than the holy water. This is, I mean, this is a revolution. If it's true, it's a revolution. No ifs, whys, buts, no, it is. Hospital mortality, 8.5 versus 40. Length of stay about the same, but then again, shorter if you look into the ranges. Duration of vasopressors, hours, tremendously shorter, 1/3. Big thing, time to reversal of shock. It's very important, critical care. Renal failure, again, amazing. Decrease in SOFA score, and Dr. Groves talked about SOFA score. Amazing, huge, yeah. And then delta in procalcitonin, we talked a little bit about it, 86 versus 33. So my concern with this study is this number here. I mean, 46% of patients were on pressors. And remember, these are all patients severe septic shock. And 40% die. Believe me, I would not want to be admitted to this hospital. I really would not. I mean, only 6% of patients who went on pressor survived. I mean, to me, it's a little bit scary. Huh? I don't know what they were doing to them, but nothing too good. Yeah, that is not our experience. And remember also, if you plot Apache 2, I am told to be stopped. I'll be stopped in 33 seconds. Yeah. If you plot Apache 2 scores into your mortality, you will see that all the Apache scores, modern mortalities are lower than plotted ones. So we are doing better than we used to. So modern trials show lower mortality than predicted Apache mortality. So this is my concern. So well-matched, consecutive patient, cheap, apparently safe, at least short term, and it's revolutionary if it's true. If it's true, we'll all do it all the time. I'll give it even to patients who don't have sepsis. So now not randomized, small sample, single center retrospective, pre and post model. Don't ever get fooled with pre and post. Many things change in time and too good to be true. Questions? Thank you. Yeah. So this is, it's in Norfolk and it's Eastern Virginia Medical Center or something like EVMS, something like that, yeah. EVMS, yeah. Yes, please. It's nothing, I don't know, but vitamin C is going to be few bucks, I mean, this is nothing in a big scheme of things. I'm sure that if this comes to fruition, it's going to cost a lot because obviously you know how, as soon as you need it, the pharmaceutical companies are going to charge you. But so far it's nothing, yeah. Yeah. Yeah, even, $1,200, if you think that the first day of ICU admission in most of the studies show that if you go on the vent, first 2 days are about $10,000, so about $5,000 a day. It's nothing. If you were to save these lives, I mean, it would be just, Sorry? No, this wouldn't be for probably out of ICU trial. We came together as a group, we debated this date, and we said for now we are not going to offer it as a standard. If families come to us and ask for it, then we will say we have this condition, which is a severe condition, it's called equipoise. It just sounds very bad to me, but what it wants to say is that you don't know benefits or harm. So you say, I informed the patients about equipoise in this condition, and on patient's family request or patient's request, we will use it. But otherwise, we don't offer it as a standard of care.
We've been debating this for like 10 years, pros and cons, and just going in there and there. Yeah. And similar studies has been done on thiamine and vitamin C. This is the first one which combination. But again, your point is people who are on pressors, and the number of people died is like anybody who's going on a press has died. Paul Merrick is a very
almost, yeah,
respected.
6
Yeah,
per day
exactly.
they
So
sent
I'm
actually
not-
2 patients there if you look with
Exactly.
pressers.
So,
I mean,
I'm not
yeah.
very convinced with the data.
Yeah, it's a little bit, it's a little bit, if we'll see, and I don't say it's not true. Don't get me wrong. I need the study. That is what I need. And if I have the study that shows me, and even, if we start to get, because now a lot of people just embarked on it, based on, not on medical literature, but based on NPR news. And so a guy from Seattle goes, they interview this big professor of medicine, say, oh yeah, we'll do it on all of, and we might have been seeing some faster resolution of and so on. If I start to get much more data, which start to point that way, it's okay. But this is really a first single center trial. It's just too little. Remember, we were doing a lot of harm to people with, or not benefit and spending gazillions, Xigris. Let's talk about Xigris. I mean, and it was much better trial, and it was still false. I mean, it was just secondary out or subgroup analysis to be, and we used it based on subgroup analysis from one single trial, and we did a mistake. It's, yeah. Yes, please, yeah.
My next, okay.
So, sorry, yeah.
Ladies first.
Yeah. Yeah.
Inova's a huge organization, so why doesn't Inova do this study then?
Yeah, doing the study in septic shock is not cheap. Even if the drug is cheap, doing the trial is extremely expensive and difficult. And why is that so? It's, for the most part, enrolling a patient into a septic shock trial these days costs at least between $8,000 and $12,000, a single patient. You would need, it's doing a septic, in old days trials were easy. We'll do double blind, we'll get a pharmacist, a statistician, and we'll document, and that's it. It's much more than that, It would also, and I'm hearing that NIH is already allocating money, but it's a big enterprise. Doing a septic shock trial is, you have to screen, depends on the study, but you have to screen many patients to enroll one. It's not that simple. Between the consent, getting in timely manner, exclusion, inclusion, it's just crazy.
Yeah, great. Thanks so much. I'm probably going to take this in a slightly different direction. We've had an excellent discussion so far this morning, a lot of great things about sepsis management, and all that good stuff. So, I want us to be careful about expending all our efforts on just preaching to the choir. We already have an engaged army, but we still have challenges with those who are reluctant to accept, some of these things and enroll patients appropriately in sepsis. So let's go, first of all, real quick to that first case that was shared about the patient who came in and had what seems to have been more like anaphylaxis. So, but then of course there was a concern that this patient might have sepsis, was allowed to be hypertensive for a protracted period of time, et cetera, until the patient was enrolled in sepsis. So I'm speaking from the side of the unengaged, the people who have not yet bought into this great concept of saving lives, et cetera, and still think and say to themselves, well, maybe it's sepsis, maybe it's not. Even as you're talking about procalcitonin, that sometimes you can have false positives, you can have false negatives. So my thing is, how do we message our recommendations? Just like we're talking about S-bar, how do we message our R in the S-bar when we're reaching out to those who are reluctant to enroll patients in a sepsis bundle? I think we should spend a few minutes in, exploring that.
I couldn't agree more, and I don't know whether. Yeah.
Okay.
Yeah, and
okay.
that.
Okay.
Absolutely, I think this is a beautiful observation. We talk about many small things, but how to move organization from point A to B, that is, it's a tough one. It's almost like cure for sepsis. Yeah, it's not easy. Yeah.
So we're halfway there. We're going to move on to our second half, which has a lot of ICU-related care when it comes to sepsis. So the next session, we're going to start with Marianne Putman and Alex Siraj, who are going to talk about ventilator management when it comes to sepsis. So I'll turn it over to them.
Okay, good morning. So I'm from MCCS, and I'm going to discuss ventilator management in sepsis-induced lung injury. So the lecture I'm going to give is going to first talk about ventilator management to decrease mortality, ancillary therapies we use in sepsis-induced lung injury, and then Alex Siraj is going to speak about ventilator-associated pneumonia, the new definition that has come out with regard to ventilator-associated events, and then there'll be time for some questions. Okay, so I have no disclosures. And a lot of I'm going to discuss is based on what's recommended in the Surviving Sepsis campaign that came out in 2016. So in Surviving Sepsis campaign in 2016 recommended this lung protective strategies, which has been discussed in the past 10 to 15 years, of using targeted tidal volumes of 6 cc's per kilogram for predicted body weight instead of the 12 cc's a kilogram that were used many, many years ago. And this is in sepsis-induced respiratory failure as well as ARDS. And then the upper limit goal for plateau pressure of 30 centimeters of water. So these pressure and volume limited strategies for established ARDS have been associated with survival benefit in randomized clinical trials. And the biggest study, which I'll show you a slide from, in New England Journal of Medicine that came out in, I think, 2000, showed a 9% absolute decrease in mortality in this, and that was the largest trial to date. So here, this study from New England Journal was saying the ARDS network came out in 2000, and here in this slide is just showing the decrease in mortality that the lower tidal volume management resulted in. Here on the x-axis is the static compliance of your lung. So as you develop ARDS lung injury, your compliance decreases. And here on the y-axis, mortality. So as the compliance of the lung decreased, when lower tidal volumes were used, you can see here versus traditional tidal volumes, there was a significant mortality difference. And again, the study showed a 9% decrease in mortality, which was significant. So in summary, we avoid the high tidal volumes and the high plateau pressure in all ARDS patients, even those with developing acute lung injury in sepsis. You initially reduce your tidal volume to 6 cc's per kilogram over 1 to 2 hours, because a large number of times patients that come from the emergency room will be at the traditional 8 cc's per kilogram. So if you're seeing acute lung injury, you want to decrease the volume to 6 cc's per kilogram. Then you look at that plateau pressure. If the plateau pressure is still high, greater than 30 centimeters of water, then you can further reduce tidal volume to 4 cc's per kilogram. And then the problem with the lower tidal volume is you need to maintain an adequate minute ventilation. And minute ventilation is tidal volume times respiratory rate. So you will need to increase your respiratory rate to get the minute ventilation where you need it, and can go up to 35 breaths per minute. Hypercapnia, a number of times, is the problem when you hyperventilate these patients with lower tidal volumes, but it's tolerable if your pH is greater than 7.2. Anything less than 7.2 will cause like hypotension, resistant to vasopressors. So we tolerate this as long as the pH is greater than 7.2. The big problem with hypercapnia is in the neuro ICU in patients with high intracranial pressure. So this is the mode of ventilation we are using in ARDS. So a new thing that's come out recently in the literature is this mention of driving pressure. And it was mentioned, a good study that came out was in 2015 in New England Journal of Medicine. And this pulmonary driving pressure is the plateau pressure minus set PEEP. Oh, I'm sorry. And it was this variable was looked at compared to other ventilatory settings like the tidal volume, low tidal volume, and plateau pressure. And in this study, it showed it increased in survival. So the pulmonary driving pressure of less than 12 to 15 centimeters of water in this study has, first of all, you have to measure driving pressure when patients are not taking any spontaneous breathing efforts. And it was showed, again, increased survival in the ARDS patients when it was less than this value. And what this pulmonary driving pressure is doing is traditionally when we adjust patients' tidal volume, we're looking at the tidal volume in cc's per kilogram. And the kilogram is based on the predicted body weight. And in ARDS, the thought is your amount of lung that's available for ventilation is much less than what we can predict based on your body weight. So the thought is with the driving pressure here, based on this equation here, you're relating the driving pressure to the reduced compliance of the lung. So looking at this variable, can we adjust the tidal volume so that it's more reflective of the reduced compliance of the lung? And that's basically the concept of this driving pressure. So this study is it came out in New England Journal 2015. It was driving pressure and survival in ARDS. And here, this is a very complicated slide, so I'm going to work you through this. So here, up here, with the three variables that are looked at in this slide, is plateau pressure, which is here. The change in delta P here is your driving pressure, and then this is PEEP. These are different subsamples of patients, groups of patients. And if you look here, when the variable that was most correlated with mortality, because here's mortality, okay, this is a slide, this graph shows increased mortality, this graph shows decrease in mortality. So as driving pressure is increased, so here is the mortality. Same here, if driving pressure is decreased, your mortality is decreased. And this study showed that this change in mortality related to driving pressure was unrelated to other variables of PEEP and plateau. And this was the variable most closely related to mortality. And here is the Kaplan-Meier curve showing the relative risk of death based on driving pressure. And as you see here, as the driving pressure is increased, so is your mortality. And the lowest mortality was at that value of 12 to 15 centimeters of water. So the problem with this study, though, it was a multi-level mediation analysis. You're looking at 3,562 patients with ARDS in 9 previously reported randomized trials. So this was not a prospective study. This was not a randomized control study. So in order for driving pressure to be really used in the clinical setting, there is a need for another study to validate this variable. Okay, so other mechanical ventilation strategies we use and that are recommended by the Surviving Sepsis campaign. A higher PEEP is better than a lower PEEP in adult patients with sepsis-induced moderate to severe ARDS. And there's moderate quality evidence showing that this higher PEEP improves outcomes. And the studies have been mainly in moderate to severe ARDS. And the thought is that it prevents atolic trauma, it opens lung units to allow better participation in gas exchange. Other thing that's recommended in surviving sepsis is recruitment maneuvers in adult patients with sepsis-induced severe ARDS. Again, it facilitates opening of atelectatic alveoli for gas exchange. And there's been studies that showed an improvement in survival. Now, what are other strategies, other than management of the ventilator, what are other strategies we can use to decrease mortalities in ARDS? So there's been, prone positioning has been used for many, many years, but it's been recently looked at in a recent study that was published in New England Journal that did show improved survival. And the study looked at severe ARDS patients with a PaO2 to FiO2 ratio less than 150. Thoughts in the past have showed that it improves lung compliance, improves oxygenation. And this study, what was different compared to other studies that failed to show an improvement of survival with prone positioning, was this study started using prone position early during the patient's hospitalization, within the first 36 hours. And again, another problem was patients weren't prone for a long period of time. So this study ensured that they were prone for at least 16 hours per day. Okay, so this is the prone positioning in severe ARDS. This was a study that showed improvement in survival in New England Journal in 2013. Now, it might be hard to see this this slide, it's just the characteristics of the patients in the supine versus prone group. The difference in these groups where the SOFA score was less in the prone group, the vasopressor use was less in the prone group, but neuromuscular blockers were more commonly used in the prone group. And here, this Kaplan-Meier plot shows that the prone group had a significant increase in survival versus the supine group. So again, this study, compared to other studies that did not show an improvement in survival, this study showed that you made a difference if you started early in the patient's admission within the first 36 hours, and that these patients were prone for at least 16 hours per day. So the patients in the prone group, 73% of the time during the study, they were in the prone position. So I think the problem with other studies, and this study suggested, is that we need to keep these patients prone for a long period of time for it to be effective. Okay, I'm just going to skip this slide, it's hard to see. Basically, it just showed that the difference in mortality was at 28 days and at 90 days, that it was significant. Also, the ventilator-free days were significantly decreased in the prone group. Okay, so the next ancillary study that we've looked at is neuromuscular blocking agents. And the thought is that neuromuscular blocking agents improve chest wall compliance, prevent respiratory dyssynchrony, and reduce peak airway pressures in ventilated patients. And then if you also paralyze patients, the thought is you reduce oxygen consumption. And that really helps in allowing us to decrease the FiO2 in patients that are severely hypoxic by decreasing oxygen consumption. So surviving sepsis campaigns suggest that neuromuscular blocking agents for at least 48 hours in adult patients with severe ARDS does improve survival. And there's been a recent study in New England Journal of Medicine that was published in 2010, Neuromuscular Blockers in Early ARDS Syndrome. And this study used cystocurium, which was a continuous infusion of this neuromuscular blocker. It was infused for for less than 48 hours. It was early during the patient's admission. And it showed here, as you can see, a significant increase in survival when the neuromuscular blocking agents were used. The mortality was 31% versus 40% of the placebo. Now, the big concern is, was there an increase in neuromuscular weakness? And if you see here, there was no significant difference in ICU-acquired paresis in those that got the cystocurium versus the placebo. And in this slide here, in addition to the difference in mortality, there was a significant decrease in barotrauma and pneumothorax in the cystocurium group. So that's another neuromuscular blockers is another re-emerging therapy. So now I'm going to speak about ventilator liberation strategy. And the Surviving Sepsis campaign recommends spontaneous breathing trials in mechanically ventilated patients with sepsis who are ready for weaning. Now the big change has occurred recently in the past couple of years, really in the past year, was when the CHEST and ATS suggested that when you do the SBT trials, you should add inspiratory pressure augmentation. So rather than just doing a CPAP trials with PEEP of 5 or just TPs, it's been shown by adding inspiratory pressure augmentation, like pressure support of 5 with PEEP of 5, significantly improved your extubation rate and decreased the duration of ventilation when this was applied. And then daily SBTs reduce the duration of mechanical ventilation as well. So having daily weaning trials is important. So here, this is the CHEST liberation from mechanical ventilation in critically ill adults. This was the official statement released by CHEST and ATS. It talked about the inspiratory pressure augmentation during spontaneous breathing trials, protocols minimizing sedation, and then this other thing that's really new is the use of non-invasive ventilation immediately after extubation. So I'm just going to talk about 3 important points that were brought out in this practice guideline. So, and again, this is just recent in 2017. The first one is for acute hospitalized patients ventilated more than 24 hours. Again, I'm talking about this. Inspiratory pressure augmentation is recommended rather than just plain CPAP. For acutely hospitalized patients ventilated for more than 24 hours, we suggest protocols attempting to minimize sedation. And again, using fentanyl is your primary, mainly pain management, analgesic management first before benzos and propofol for patients that are ventilated. And then for patients at high risk for extubation failure who have been receiving mechanical ventilation for more than 24 hours and who have passed SBT, they recommend extubating patients directly to non-invasive ventilation. So who are the patients that are high risk for extubation failure? There's no clear description of who's considered high risk. Some of the studies have suggested those who have comorbidities like COPD, CHF, those that are hypercapnic during the SBT trial or immediately post-extubation, those who have expiratory stridor. Those are the ones who are, when you look at different studies, are considered high risk for extubation failure. And they suggest going directly to non-invasive ventilation. Here, this is just, the summary of the evidence that ATS and CHEST used. There was 3 trials that showed that SBT with pressure augmentation were more likely to be successful in extubation, higher rates of extubation success, meaning they didn't have to be reintubated, and they had a lower ICU mortality. When they used protocolized sedation group and minimizing sedation, it showed a shorter ICU length of stay in the study in looking at the trials that supported their recommendation. And then there was an aggregate analysis of 5 randomized control trials that favored non-invasive ventilation immediately after extubation in those that have a high risk of extubation failure. And then the last, this is near the end of what I'm going to speak about. Then Surviving Sepsis campaign states that using a weaning protocol in mechanically ventilated patients with sepsis-induced respiratory failure can tolerate weaning, in patients that can tolerate weaning. It showed that protocolized weaning ended up with shorter weaning duration, shorter ICU length of stay, and that the mean duration mechanical ventilation was reduced by 26% in protocolized weaning groups. And this was shown mainly in medical ICUs and surgical ICUs. And here, this was a Cochrane database analysis of 7 randomized controlled trials. And this here on this plot just showed when you pooled all these trials together, that in the duration of ventilation favored protocolized weaning rather than usual care. Okay. So now Alex is going to speak about the new definition of ventilator-associated pneumonia for the rest of their talk.
Good morning, how are you? I would like to just add one of the topic that is the most hottest topic right now regarding the ventilator-associated pneumonia, also known as VAP. Just to kind of give you a slight definition, the VAP is a type of a lung infection that occurs in people who are on mechanical ventilation breathing machine, of course, in the hospitals. As such, a VAP is typically affected critically ill persons that are in intensive care unit. VAP is a major source of an increased illness and death. With that said, VAP is also a major cause of hospital morbidity and mortality despite of our recent advances in diagnosis and accuracy of management. However, as taught in mechanical sciences, prevention is better than a cure is probably more appropriate as concerned to a VAP, because the fact is that it is a well-preventable disease, and a proper approach decreases the hospital stay, cost, morbidity, and mortality itself. If you're looking, I'm trying to use the cursor. So if you're looking at how the new definition was actually used, some of the stuff that they were comparing based on 2013, I had pulled some information just to kind of give you more detail about the stuff in here. So in January 2013, surveillances for ventilator-associated event replaces the planned surveillance as ventilator-associated pneumonia. They're not thinking just only this is just a VAP. This has to do more than just a ventilator-associated pneumonia. It has more events that causes the patient to have VAP. With that said, it focuses objectivity, reliability, and ability to automate and identifies the broad range of a condition and complication occurring in mechanically ventilated patient, which that means that patient with a pneumonia, ARDS, atelectasis, pulmonary edema, which may be preventable. This next slide that we have is, this is actually done currently by the CDC. It is a protocol. If you actually go into the website, it says cdc.org. They have what it's called the VAP protocol. If you click on it, of course, this pulls up. This is a protocol that we follow in the hospital itself. If you notice the first part of it, it says the surveillance definition. It is for acute, long-term acute hospital and acute rehabilitation center. It is only mainly focused on patients that are age of 18 or greater who are on mechanical ventilation greater than 3 days. If you note that the patient in the rescue ventilation, this exclude patients that are in high flow frequency ventilation or ECMO, or the patient that are actually in a prone position that are actually excluded. Second part of it is the patient has a baseline period of stability or improvement on the ventilator, and that's defined greater than 2 days. Stability decreases if you change any FiO2 or PEEP after the third or fourth day, then of course, not only that you're treating the hypoxemic issue, but you're actually putting the patient in high risk for the VAP itself. Lastly, of course, would be after the period of stability and improvement of the ventilator, the patient has at least one of the following indication from worsening oxygenation, and that's the minimum daily FiO2 value greater than 20%. So I kind of printed out a little stuff right here to give you an example. So assume a 57-year-old gentleman was actually admitted to the emergency room, and he came in with a severe community-acquired pneumonia and was admitted to the MICU day 1. The patient is stabilized and improves on day 2 through 5, but the daily minimum FiO2 was only 35%. So his requirement was only 35% FiO2 for the first 3 to 4 days. On day 4 and 5, and then on day 6, the patient experiences respiratory deterioration and requires minimum at least 60% FiO2. So we actually have gone up 20 to 25% above the baseline of what the patient was on initially the first day on 35%. And that itself, based on the CDC, says that if you are increasing the FiO2 or the PEEP on the day 6, which is of course the day that we made the change from 35% FiO2 to 60%, the patient has the event as far as increased chance of VAP. The following is just, this is just gives you a lot of the more detail as far as the infection-related ventilator-associated complication. A lot of the stuff that has actually been talked about, one of the things that I wanted to mention is VAP itself actually been sort of redefined. The Center for the Disease Control for Prevention recently released a surveillance definition. This is their definition is saying that the complication in the ventilator patient, ventilator-associated event, they don't call it actually VAP itself. It replaced the ventilator-associated VAP. It consists of a ventilator-associated condition, VAC, infection-related ventilator-associated complication, which is IVAC, which is possible, and also a possible VAP. And this is during the duration of the ventilator. At least 4 days is required to diagnose a ventilator-associated event. However, the observed duration of mechanical ventilation, less than 4 days as many previous studies. This was actually evaluated on impact on the ventilator-associated event on a clinical outcome in a critical ill subject who required mechanical ventilation greater than 4 days. The ventilator-associated pneumonia bundle, this is something that I could give you more detail as far as the recommended prevention of the VAP. Of course, currently, as you know, all the healthcare bedside nurses, respiratory, we wanted to make sure that we keep the head of bed elevated at 30 to 45 degrees. This is all the stuff that we're talking about up to the 7 topics. These are all the prevention of VAP. So daily sedation interruption. We used to call it sedation for vacation. I don't know if the Inova Fairfax has uses it now, but it used to be at 5 a.m. We used to stop, the nurses used to stop the sedation. And by 7 o'clock, when we got reported by 7:30, 8 o'clock, we switched patient to CPAP, or now what we're using, of course, is CPAP, a 5 fiber pressure support. Try to do the SBT to try to minimize the length of stay of the ventilator, so the faster you can extubate the patient, the higher chance for their survival, and of course, better off to be out of the ICU. Daily sedation interruption, of course, is one of them. Use of the subglottic secretion. So as you notice, if you work in an ICU, you notice that we have what is called high-low, and high-low is actually connected, it sits right above the cuff of the endotracheal tube, and what it does, it gets connected, we connect them to 30 to 40 centimeters of water, intermittent, not continuous. And what that does is basically for any oral secretion, anything that actually drains down to the lung itself, since it sits above the cuff and the cuff is inflated around the tracheal wall, we wanted to make sure that the suction is applied to make sure that that actually is a prevention for the VAP itself. Avoidance of scheduled ventilator circuit change. The old method was that we used to change every 48 to 72 hours many years ago, because I've been here a long time. Many years ago, we used to change the ventilator circuit every 72 hours. The study shows now that do not make the change unless you have, lots of blood, of course, in the tubing, or looks filthy or whatever that you have to change. But generally, we try to avoid not changing the ventilator circuit at all. Oral care, which is very good. All the nurses are here, very good about doing the chlorhexidine of every 4 hours. We do oral care here. DVT prophylaxis within 24 hours of start of ventilation. And of course that we use the leg compression, of course, to minimize DVT. Peptic ulcer prophylaxis, of course, within the 24 hours of start of ventilation. These are all recommended as far as minimizing VAP. This is just a study was actually done, an original investigation in September 2016, association between the ventilator bundle and a component of the outcome. Did you want to talk about the last one? Or you want me to talk about it?
Just quickly,
Sure. Just to kind of give you an idea, oops, sorry, I went too forward. This is just actually a retrospective coherence study. It was done around about 5,500 patients on a ventilator patient for at least 3 days. What they were looking at is the measure effect on the time of extubation. This is the ventilator-associated event versus VAP and a ventilator mortality. Sedation interruption and SBT was trial associated with less time to extubation. Hit of the bed elevation, as we mentioned before, in DVT prophylaxis associated with a less time of extubation. Oral care, again, this is just more reiterating of what we just mentioned about increase of ventilator mortality. And then, of course, prophylaxis associated with an increased risk of VAP. The last part about it, this is, of course, the last slide. We are here for all the respiratory therapists here at Inova Fairfax Hospital. We actually take a measuring tape and measure every patient. We don't just go to the bedside and assume that the patient is 5'5" or 5'7" or 6 foot. We actually have a measuring tape that we measure the patient. So the strategies is to use 6 to 8 cc per kilogram per ideal body weight. And that itself, I'm going to let Dr. Putman mention a little detail about it.
Okay, this is just a summary slide, just quickly. So again, the lung protective strategies, we are using that and to continue using that. The role of driving pressure, though, in our management of respiratory lung injury with sepsis, we're not sure yet, and further studies are needed. Higher PEEP, higher PEEP and recruitment maneuvers are, again, ancillary other strategies we can use in ARDS and severe hypoxia. There is a role for prone positioning. There is a role for neuromuscular blocking agents early during ventilation. Ventilator liberation strategy is to use a weaning protocol in daily SBT trials, and these should have inspiratory pressure augmentation, and this has been shown to improve survival, decrease duration of ventilation. And then what Alex was talking about, the new definitions for ventilator-associated events, ventilator-associated conditions, IVAC and VAP. And the important thing here, which is different from prior definitions, is there is no role for chest x-ray. That's the new thing in in 2013 guidelines that were submitted. They're looking for an infiltrate on chest X-ray is not useful in definition.
Great.
Okay.
Any questions?
Great, thanks. We're going to hold questions till the end because we're a little bit behind right now. Thanks, guys. We have Megan, Tarek, and Sonia Astil coming up next to talk about ICU management of sepsis. And when I asked Megan to do this originally, it was like one of those cartoons where the eyeballs pop out and attached to springs. She's like, oh, just a very small topic to cover, huh? ICU management of sepsis. So we're a little behind, but we're going to just kind of push things a little bit forward and cut into a little bit of the discussion time, but we'll try to save the questions and conversation for the discussion time that we have before lunch. So I'll turn it over to them.
Say what? ICU management in 30 minutes or less. Here we go. Good morning. My name is Megan Tarek. I'm one of the intensivists here at Fairfax, and my partner Sonia here as well. We'll be talking about some, our slides are up, some key management components. Nothing to discuss and nothing to disclose. Yeah. So I think a key objective here, and hopefully you've seen this, is appreciating the need for a multidisciplinary team approach for sepsis treatment and management. We'll talk briefly about some special patient populations, acknowledge some best practice care delivery with respect to early sepsis recognition and prevention, sort of reiterating and echoing what we've talked about earlier on today, discussing significance of delirium and impact on patient outcomes, and then goals of care and the role for surrogate decision markers.
If you can talk into the mic, it's being recorded.
What's that? Oh, okay. Okay. So, talking briefly and echoing, identifying these patients once severe sepsis is identified, and especially with organ system dysfunction, this is an emergency, and requiring multimodal and time-sensitive interventions, as we've talked about before. The septic shock patient gets a fluid bolus, lactate measurement, blood cultures prior to antibiotic therapy, and then early and appropriate antibiotic therapy. And I'll touch on a couple studies here too, reiterating the time sensitivity of some of these interventions. So identifying organ system dysfunction and echoing again, respiratory failure, P to F ratios less than 200 if only lung dysfunction, less than 250 if there's another distant site of infection. Metabolic, and any unexplained acidosis or lactate greater than 1.5 times upper normal. Tachycardia, mean arterial pressure less than 70, renal function, urine output described as a urine output less than 0.5 cc's per kilo per hour despite that fluid bolus. And then hematologic dysfunction as well. The sense of urgency can be conveyed with respect to acute kidney injury. I mentioned measuring that acute kidney injury by low urine output. But for each hour, the study that I'm referencing here, acute kidney injury and septic shock. So this was more than 4,500 patients that showed an acute kidney injury was associated with a significantly higher odds of death, both in the ICU but in the hospital in general. AKI defined here is less than 0.5 cc's per kilo of urine output per hour for 6 hours. An increase in serum creatinine of 1.5 times the baseline, or increase by 0.3 milligrams per deciliter within 48 hours. The risk of AKI was related to severity of hypotension. So the longer the patient's mean arterial pressure was less than 70, 60, or even 50, portended an increased risk in acute kidney injury by 2, 5, or 22%. So the longer the patient is hypotensive, the higher their risk of developing acute kidney injury, and with the incumbent risks to mortality that portends. Duration of hypotension as well is a critical determinant in survival of septic shock. So once identified, these are patients you need to jump on and jump on fast. And then this study has been reiterated a couple times, I think, throughout this talk. So time to antibiotic therapy is so important, so critical. Each hour that those antibiotics are delayed can increase mortality 7.6%. So now jumping to the ICU. So those patients have been identified. Why do we go to the ICU? Those patients may require organ support. Intubation, mechanical ventilation, as Dr. Putman and Alex just talked about, vasopressor therapy, which my colleagues following us will talk about, may require renal replacement therapy or mechanical circulatory support as well. Once it's recognized, early involvement of your critical care team is essential. Keys to mobilizing some of these resources. In the ICU, so we've identified a patient, we've started our treatment strategy in mitigating their hypotension. We're also simultaneously searching for a source. So identifying the source of infection. If it's not immediately apparent, imaging, so plain films, CTs, MRIs, ultrasound potentially, even lumbar puncture if meningitis is suspected. And then once that source is identified, we want to get control of it. So early involvement of your surgical consultation is important here. In case of OR control or bedside debridement, drainage of fluid collection. So our interventional radiology colleagues are crucial here. Also general radiology colleagues as well if we need to get a drainage tube placed. We can place bedside drainage tubes for parapneumonic effusions, for instance, or ascites if that's thought to be the source of infection, but involving some other colleagues here. Special populations, certainly anytime you have a pregnant patient that gets our attention, you're dealing with more than one person at the time. So involvement of the OBGYN team early is effective here. And then trauma populations, keeping in mind that more than one source may be possible. Reassessment. So we've cast our net of intervention, and then we go back and check and see how is the patient doing. So key to the CMS requirements of reevaluation, that DOT sepsis phrase to reevaluate, have things worked? Are things getting better? So we're looking, how's the patient doing? Do they feel warm, well perfused? Is their urine output increasing? Has their lactate cleared? Is their respiratory function improving? Is their coagulopathy getting better? Assessment of fluid response. So passive leg raise will also involve bedside ultrasound assessment as well. However, passive leg raise has been established as the new gold standard with respect to assessing fluid responsiveness. And then need for vasopressors. I'm going to skip these. So a word on delirium. So best prevented, because once it is recognized, it portends an increased risk of mortality to the patient. Delirium can be unrecognized in 66 to 84% of patients in the ICU, acute care, and emergency departments. The reason for that, maybe they may be on the hypoactive delirium side, but carrying an equal risk of mortality. Sonia's going to talk about CAM, ICU, assessment methods for delirium. But what we can best do is prevent it. So sedation cessation, as Alex had mentioned, sedation vacation, sedation cessation. So the less the patient needs from a sedation standpoint, the better. You should be establishing your sedation goal at the bedside with your clinician. The goal would be a RASS of 0, so awake and not in distress. However, sometimes that goal may be deeper sedation, for instance, if the patient is paralyzed on neuromuscular blocking agents. So it's important to establish that sedation goal. Pain management, which is why narcotics should be first line for your sedation. Sensory stimulation, early mobilization, we'll talk about this in a second, and then promotion of sleep and nutrition. I'm gonna hand it over to Sonia for a bit.
Thank you.
Try to hear my voice.
Good morning, everyone. we see so much delirium in the ICU, and I think that is without doubt recognized through most institutions. And we see probably more hypoactive than hyperactive, and those are the folks that we probably are doing a very huge disservice to. So I want to talk about patients who have underlying comorbidities. Something as simple as hypertension is actually putting patients at higher risk for delirium, along with histories of alcoholism or the severity of illness. We know the presence of coma is really significantly a cause of delirium as well. And we all know the recent literature around benzodiazepines and many other drugs, including some of the antibiotics, some of the analgesics that we give, are sources of delirium as well. So the literature is very, very strong with longer length of stay, hospital days, of average of 10 days for delirium patients, higher ICU mortalities, and higher hospital mortalities, along with post-ICU cognitive impairment. And the cognitive impairment is sometimes unresolved, and so the folks that you think you're going to send home will be dependent on a nursing home or not able to balance their checkbooks, or if people do that any longer. So the delirium doesn't just clear up and go away, it often lingers for the rest of these patients' lives. So these are some studies that we took from to get this information. This is a New England Journal study. Incidence of risk factors and consequences, long-term cognitive impairment. In 1990, Dr. Sharon Inouye, did the first CAM, the confusion assessment method, testing for that, and it is been shortened substantially to do a CAM ICU now, which we look at 4 different factors. We look at a change in baseline status, and that would score a point. You can see the chart that we're using here. A fluctuation of mental status within the first 24 hours. So you have to have at least one of those. And did the patient have difficulty focusing attention? So you're looking at attention, and so those 2 have to be scored positive. And then either 3 or 4 is the patient scoring anything other than alert and calm, that gets scored. And then is the patient's thinking disorganized? So looking at those 4 areas, you can tell very, very quickly if your patient is positive for delirium. So that's something that immediately needs to be discussed as a team, and what the approach is, what might be causing it, and where to go from there. There's some literature on hypoactive delirium, and that again is what we see most. And good things to know from a team perspective approach to these patients: they don't like to be touched, that scares them. Things as simple as a blood pressure cuff on their arm going off every 15 minutes will think that they're being inappropriately touched many times. So you have to really think about what we're doing as care providers and how we're interacting with those patients. One of the things that they need most are people that know them and can be with them. So please don't limit their visitation to their family. I'm going to let you talk about this one, Megan. Okay.
So once identified with our CAM ICU tool, what do we do about it? Certainly identifying it and then developing a team-based approach. So sedation interruption or a light level of sedation, allowing the patient to interact with the environment as best they can. Spontaneous breathing trials, I think that was presented earlier. Atypical antipsychotics if needed, for instance, quetiapine or Seroquel in this case. Analgesia first sedation, so in this case fentanyl before you go to propofol. dexmedetomidine instead of benzodiazepines if you have somebody who's difficulty weaning from the ventilator may be employed here. Promoting good sleep hygiene, so optimizing the environment for the patient, lights on and bright during the day, off at night, trying to cluster care, controlling light and noise in the ICU, which can be difficult to do. And then decreasing stimuli at night to promote sleep cycles. So what we can do, or what we are doing for these patients, really makes a difference in the long run and help to mitigate their delirium. And you've heard this before, I can't say it enough. This definitely requires that interdisciplinary ICU team approach. So the bedside nurse, the pharmacist, the physical occupational therapy, respiratory therapy, clinical nutrition, critical care MD, and then the patient and family engagement, as Sonia touched on, I think is crucial here, and we'll talk about some more of that in a minute. Mobility. We're learning more and more prolonged stays in the ICU are associated with weakness, functional impairment. A patient may lose up to 20% of their muscle strength in just 1 week of immobility while in the hospital. So daily progressive mobility can decrease delirium by 40% here. And so it's crucial to develop and implement a plan aimed at progressive mobility. So involving your physical therapist. This often takes a team of people to get the patient, especially on a ventilator, up and moving around. It's possible. We have patients walking around the units on ventilators, and it goes miles in terms of helping to prevent and treat that delirium that we talked about. Nutrition. We'll talk about this like a prescription, like any other. We know critical illness is associated with a catabolic stress state. So objectives of nutrition in the critically ill patient to help mitigate that metabolic stress on the patient, prevent further oxidative cellular injury, and then help them to modulate their immune response as well. So early enteral nutrition, as soon as it's appropriate to initiate it, you should do so. Glycemic control, typically will keep the glucose under 180. And parenteral nutrition. So we'll typically not start TPN earlier than 7 days. There's really no benefit to it. But with respect to enteral nutrition, and we'll talk about some tube feeding, volume-based protocol in a second, but helping to treat that like you would a prescription, like any other drug, in terms of optimizing the patient's nutrition. Again, starting that as early as possible. So starting the nutritional tube feeds at a calculated hourly goal rate and advance that immediately to the goal rate, striving to meet a daily volume goal versus just that hourly rate. So for instance, if a patient's tube feeds are held for a procedure, they can catch up with that total daily volume goal rate. And then adjusting them as needed to compensate for the volume lost from holding the feeds. So they may catch up in the subsequent hours following a procedure.
This is the protocol that we use in the ICUs for nutrition. And so if the volume left to be fed, so if you're starting out with 720 cc's as your goal, if I hold that feeding for an hour, you can see that if I'm at 24 hours, where's the light on here? Is that this one? This one. So if I have a 720 goal, and my it's going to be for 30 cc's per hour, if I hold that for an hour, you can see now I'm going to set my pump to 31 cc's for the rest of the duration of the 24 hours. So if you hold it for 3 hours, you can see that you're going to go, you're going to just pick up those where you left off at the 3 hours, and you're going to then put it on 36, for example, for the rest of the time. And that's been working out pretty well. People are getting their nutrition goals met. For residual volumes and promotility agents, we're looking at residual volumes. We check every 4 hours. This is a high number, but it's really what the literature is saying. So if you're 500 cc's or greater of enteral feed is aspirated, you want to hold the feed for 1 hour. But during this hour, you want to refeed that 500 and give the promotility agent. So usually it's Reglan that's being ordered, and then we recalculate the volume and increase according to that reference chart.
I wanted to talk also about family engagement and empowerment, sort of as an extension of patient-centered care. Once the patient survives, hopefully, their critical illness, they're going to need the family to be their support following that critical illness. So involving the family up front as early as possible is important. And this can be done, hopefully, if your patient's hopefully they're not coding, but you could involve the family in resuscitation efforts, depending on your comfort. Scheduled time-based meetings, improving communication about all aspects of care. So, for instance, you can expect to hear from myself or a member of the team tomorrow at 12 o'clock, or certainly earlier if things change or if there's a clinical change for the patient. But that can increase your likelihood for successful discussions about goal-directed care when those goals may shift from resuscitative or more towards a palliative endeavor, potentially. Integrating family members into bedside care, educating family members, helping them support their loved one as well, can help encourage early mobility, so engage them in helping to get the patient up and mobilized. That can help to reduce restraint use, reduce total vent hours, patient days, and length of stay, all of these things that we're talking about in terms of metrics of why it is that we're doing what we're doing. I think that can really go a long way. Reduced family participation is associated with increase in unnecessary treatments or increased in physician-family conflicts. So, I think communication goes a long way with respect to what our goals are, what we're looking for in terms of how our patients are doing, and then when things change, if they change, kind of transitioning to adjusting your goals of care. So certainly considering family dynamics, cultural impact, and spiritual preferences are important with respect to who will be involved in decision-making for that patient. In the ICU, decision pace may be very rapid if patients are rapidly changing in terms of their clinical course. Surrogate decision makers are common, so identifying that person early up front, if possible, to involve them in those decisions. And then, it's often misunderstandings about code status may lead to unwanted interventions. So I think those goals of care discussions can help to isolate the interventions from the larger clinical outcome and the larger goals of care. So having those conversations up front can help to avoid a lot of pain and suffering for the patient. So in summary, because I'm getting the time, appreciate time-sensitive identification and treatment strategy. So, we've been reiterating that early involvement, upfront involvement, and caring for the septic patient. The multidisciplinary team effort, that's so critical when caring for these patients. Identifying patients at risk for and develop strategies to prevent and then treat delirium if it develops. And then goals of care conversations, helping to avoid unwanted interventions. ICU management in 30 minutes or less. Any questions?
Thank you. That was a huge task to get done in less than 30 minutes. So next up we have Aditya Kasarabada and Mary Bradbury, who are going to talk to you about fluid therapy and vasopressors in sepsis. I think that part of what we're hearing more and more from all of our speakers today is about the resuscitative efforts around patients with sepsis. You'll hear things today that may, if you're not at Fairfax, some of the things you might hear are probably new to you, that you may want to consider taking back to your other hospitals. So I won't delay.
Excuse me. This is reverse, and the green line is the laser point. Hi.
My name is Adi. I'm one of the critical care attendings at Innova Fairfax. So in 20 minutes or less, we're going to talk about fluids and vasopressors. So this is a really abridged version of a talk, just so that we get some basic ideas about what we can, what are some of the newer literature which is out there. And Mary is going to follow up with talks on vasopressors and some of the data behind it. Do not have any conflicts of interest for this lecture. So what we're going to do is try and understand different options for fluids, look at some of the evidence behind it, and look at some other evidence that is there for the vasopressor therapy. Okay, so let's start with a simple case. 40-year-old diabetic comes with progressive increase in shortness of breath over 2 days, associated with fevers, cough. In the ER, his vitals are 76, blood pressure of 76/40, heart rate of 122, respiratory rate is 26, satting 86% on a non-rebreather. So your typical septic shock patient that we get all the time, right? Patient intubated and resuscitated in the ER. He's 80 kilos and 160 centimeters tall. The initial ABG is given there. So besides drawing labs, cultures, antibiotics, intubating patients, how else can we resuscitate this patient? And we've also given the fact that the patient's lactate is 5, and you have a basic chemistry which is given there with a creatinine of 2.5. Okay. So this is your chest x-ray. I mean, I hope it projects well, but basically diffuse bilateral dense opacities in all lung fields that you can see there. Okay, options, 2-liter saline bolus and start vasopressors, 2-liter plasmolite bolus and start vasopressors, just start pressors, 2-liter bolus of saline, and then followed by more based on fluid assessment with IVC collapsibility, pulse pressure variability, and vasopressors, or the last option is with plasmolite. Okay, so keep that question in mind. We're going to get back to it and sort of go through the options there. Some background on fluids. This is the most common intervention done to a hospitalized patient. This is even more common than putting oxygen, and we all know that everyone gets put on oxygen as soon as you enter the ER. The origins for fluids can actually be traced back to 1831 cholera epidemic in England. Thomas Latta and O'Shaughnessy were the first ones to figure out giving fluids was actually helpful for treating cholera. So this is from the original paper, 2 drachms of muriate, 2 scruples of carbonate of soda, and in 60 ounces of water. Don't ask me to translate what that means, but the bottom line that ends up is they had sodium chloride, sodium carbonate, bicarb, potassium. So this is sort of your rudimentary modern fluids that we are starting to see way back in 1831. Okay. As the fluids have evolved, there were different versions of it. The one which was actually a lot more useful was their solution number 4, which actually patients did better on. Ringer's lactate came out in 1883, I'm sorry. And there were further ones. Somewhere around 1900s is where saline sort of started coming out. Now, this is the concentration of saline, 154 milliequivalents of sodium, 154 milliequivalents of chloride. Which is what we use today also. So the blood. This is when they were trying to figure out where actually the 0.9 saline came from. At that time, 0.6 was considered physiologic, and then those people started checking the tonicity of the blood. And one of the authors wrote, the blood of the majority of warm-blooded animals, including man, was isotonic with saline solution of 0.9% and not 0.6% as was thought. The scientific evidence for supporting the use of saline in clinical practice is solely based on this one in vitro study done back in 1900. How it became so popular are many theories. One of them is during the World Wars, it was easy to carry salt and water and mix them up, and so that became the choice as a resuscitative fluid. Okay. If anyone wants to read, this is actually a very good review article in New England Journal back in 2013, looking at various resuscitative fluids, when they cannot be used, what are the benefits and side effects of each one of them. I suggest that really looking through this paper because I think it's a very informative read. Common fluids that we'll sort of talk about and we sort of see nowadays are saline that we're talking about, gelatin or albumin, depending on which hospital you're at. Those are the ones which are used in the United States. And plasmolite, which, as I'll show you the data for it, we started using a lot more of in Fairfax. So there's normally when we think about fluids, there's some simple questions to ask for, right? Like, so are colloids better than crystalloids? How much fluid to give? And my favorite, is saline a good choice? So historically, people think of fluids as crystalloids, as they're cheap, they're safe, they have slower action, and they are less sustained. Colloids are more expensive. You can give a lot less to resuscitate patients. They have faster action, they have a more sustained action, but they have more toxicity and side effects associated with it. Some of this comes from a 1976 paper. What they did was they tagged albumin on patients and tagged the resuscitative fluids post-op, and they with the radioisotope, and actually tried to see how much volume expansion actually occurred with each liter of different concentrations of fluid. So the first one that you see here is a liter of dextran causes your plasma volume to go up, your circulating volume to go up by about 700 cc's. Albumin does about a little over 500 cc's. And the last one is actually saline, which is about, or any other crystalloid, which does about 300 cc's. So that's your circulating volume that goes up. So about a third stays back in the blood vessels. Whenever we talk about fluids, the SAFE trial gets talked about a lot. The SAFE trial was a multi-center randomized study in Australia and New Zealand. What they did was they randomized 7,000 patients to either receive albumin or saline, and then they looked at their outcomes, which the primary outcome was death at 28 days. What they found was there was no real difference between saline and albumin. So they did a lot of analysis, basically saying like there was no difference between colloids and crystalloids, and this is the basis for us giving a lot more crystalloid for resuscitation as opposed to colloids. Now, that's not the only finding that was there in the paper. There were more findings that were present, which didn't get as much look into it. And one of these I'll point out right here is the one in sepsis. If you look at it, it's starting to favor a little bit on the albumin side, and if you look at trauma, it's starting to favor a little bit on the crystalloid side. We'll get back to this one towards the end of the talk, but one of the thoughts at that time was why it's actually albumin causing worse outcomes in trauma was it raises your ICP, and so people are having neurological injury during resuscitation. So when we saw right here that sepsis is looking might be better, even though the overall it did not show any difference, the same authors actually did a secondary analysis on their data. It was published a couple of years later, where they looked at pure septic shock patients, and here they actually found that albumin was slightly better than saline as an initial resuscitative fluid. So this was followed up by the crystal trial, which was the colloids versus crystalloids as a resuscitative fluid in the critically ill patients. That was their acronym. So what they did was 57 international centers resuscitated patients. They got either pure colloids during resuscitative phase or pure crystalloids. They didn't put a restriction on what kind of colloids or crystalloids were given. So as you can see, there were many different options that were given. We're not talking about maintenance fluids here at all. We're just talking about patient came in, hypotensive, how do you resuscitate them? What they found was there was no real difference at 28-day mortality, but at 90-day mortality, it actually favored a little bit towards the colloids, I'm sorry. And so they actually started doing secondary analysis on them, and they found those all being driven by one subgroup. hydroxyethyl starch versus saline, and the hydroxyethyl starch patients were actually doing better. And in the interest of time, I'm going to cut through some of the, I did not put the other slides up because this was further investigated by looking at hydroxyethyl starch versus saline and hydroxyethyl starch versus Ringer's acetate. And it turned out that it wasn't exactly the starch that was doing it, it was actually the carrier component of the starch. That was a big difference in the two groups. Okay, so some lectures are going to talk about like how much to actually give patients, and there are many ways of doing this. The 2017 sepsis update also sort of suggests, gives strong recommendation to actually doing volume assessment periodically in patients. What you or your institute believes in is it's a matter of preference and training. The choices are pulse pressure variability, IVC collapsibility, cardiac output monitoring, arterial waveform analysis, and the old warhorse, the CVP. There are many others. Every year there's a newer assessment way of coming up. So it is, you have options, but the idea is give somebody fluids and reassess whether they need more or not. Okay, so back to our patient. Ended up getting 2 liters of saline because that's what his 30 cc's per kilo was. And then received 2 more because the IVC was collapsing and it was greater than 30% at that point. So now you have, now you have the repeat BMP where the sodium's, if you remember, the sodium's gone up, and I've just highlighted the changes here. The chloride's gone up, the bicarb has gone down on patients, but the lactate has actually improved. Repeat vitals are better. They're on a little bit less FiO2 and a little bit more PEEP, but the blood pressure is now better on this patient. Okay, so we gave a lot of saline, and you saw that the chloride went from 80s to 114. So is that a good thing? Does that help patients? Does that hurt or not? So this was a question that was asked in the early 2000s, and there were some animal data. People started doing animal models on this, and initial animal data showed that the chloride concentration, as it gets worse, you have worse outcomes on patients. You have more acidosis. The factors which are associated with sepsis, the TNF-alpha, the IL-6, and the IL-10, all their levels started increasing in patients, showing that they were actually markers of poor outcome. There were a couple of different animal models which they were tried just to make sure that it was not the actual animal that was doing it. It was actually the resuscitative fluid that was doing it. This was followed up by a retrospective analysis looking at volume resuscitation and the chloride load that patients get during the volume resuscitation. So the retrospective review of EMR where they had about 90,000 patients in the original database, and then they actually weaned it down further. What they found was in the first 72 hours, as your chloride load increased from baseline to whatever it was in 72 hours, your mortality increased. And this was an independent predictor of mortality. It was not as a thing to say that the patients were more sick, they needed more fluids. It was when they controlled for those factors, it was still an independent predictor of mortality. They did some lovely analysis to actually take the amount of fluid out to come to that conclusion as well. So the authors went one step ahead, then they actually started looking at larger database. This is from a database of 600 hospitals in the United States. So it's one of the largest databases out there in the world. And so what they actually did was how much balanced fluid somebody got versus how much saline they got, and to compare if there was a dose-response relationship or not. And so what they found was as the amount of balanced fluid started going up in patients, their mortalities, the sepsis mortality actually dropped. The more balanced fluid they got, the better they were. And the in-house mortality dropped, the length of stays also started dropping too. So what have we seen so far? So we've seen no basis for saline, no difference between colloids and crystalloids. although albumin or colides may be maybe beneficial early in septic shock and worse in trauma, and increasing levels of chloride can have worse outcomes, right? So chloride is, when saline is bad, now what else? Do we have other choices or not? So there are a few other choices. I have just listed a couple of them, which is plasmolite and isolite, which are available here. These have less sodium. Less chloride, and they are more balanced, so their pH is more physiologic, around 7.4. For reference, the pH of saline is 5.9, as opposed to the physiologic 7.4 that we have. Trauma actually took the lead in this. This is the first randomized controlled trial for early resuscitation of patients. This was done in trauma patients only back in 2014. And what they looked at was the amount of labs that were drawn, if there was changes in electrolytes, and how fast you could actually resuscitate patients. And they found that plasmolite versus saline, plasmolite actually did better. This was an exploratory study. There's a large-scale trial underway right now in trauma patients for the same purpose. So the surgeons went further, and they looked at all abdominal surgery patients, looking to see if if they got pure balanced fluids versus saline, and if there was any actual difference between the two of them. And what they started finding was the length of stay was actually less for patients receiving balanced fluids post-op. The ventilator days was less. The amount of times you needed, the length of the time that you needed the ventilator was also less. So better and better outcomes for using more balanced solution than saline. We're talking about trauma and surgery. So this is a recent article which came out in 2015, looking at patients in SIRS and sepsis, seeing if these kind of outcomes were replicated there as well. And they adjusted the patients for Apache scores for balance versus saline. What they started finding was when you start adjusting, they have better outcomes in infectious component, in respiratory failure, and cardiac complications all started actually reducing when it came to using balanced fluid. Length of stays went down, readmissions went down, and a lot of in every organ system there were better outcomes that we could start seeing. So where does this all lead us? The bottom line is this: one size does not fit all. Know what the patient has and what you're actually trying to achieve in their resuscitation. In certain cases, saline might be the answer. In certain cases, balanced fluids might be the answer. In certain cases, albumin might actually be the answer. As my favorite Bond would put it, choose your resuscitation fluid wisely. LR can cause hypotonicity, the starch can cause AKI, plasmolite can cause alkalosis, saline can cause acidosis. So know what your clinical setting of your patient is and how some of these things actually impact. We have started going more towards balanced fluids because as more trials start coming out, you're starting to see less, like in the era where we are driven by length of stays and mortality, like trying to reduce how long patients spend in the ICU. Balanced fluids are becoming the first line for resuscitation now. Thank you.
All right, everything you need to know about vasopressors, and then closure, and then lunch for you guys. So when fluids don't cut it, going back to the most current sepsis guidelines and iterations in the past as well, you're all very familiar with our MAP goal of 65 in patients with septic shock. And Dr. Grove spoke earlier about a trial that evaluated a higher MAP goal as well and found there to be no benefit but increased harm in the sense of arrhythmias. Another study that looked particularly at early versus delayed administration of vasopressors, similar to antibiotics and all of the other care that we're doing in this early phase, emphasizing the importance of early detection and management, showed that for every 1 hour delay in vasopressor initiation, there's a 5.6 increase in mortality. Now, this was a small single center study, but it just emphasizes the fact that earlier reestablishment of adequate perfusion is critical for these patients. This was the study that Dr. Grove referenced earlier, and the one caveat I will add is that in a subgroup analysis of patients with hypertension, they did find a decreased need for renal replacement therapy. So as we've been learning today, we have goals, but tailoring goals to specific patient comorbid conditions is very important as well. So how do we pick our vasopressors? We've got the ones that are in the code cards that are just easily available, and then more and more we are getting actually new literature despite the fact that these are very old medications to help guide our choices. But I wouldn't be a pharmacist without talking about the pharmacology of these medications. So in this chart here, I just want to show you the difference in effect. So highlighted in the top right quadrant is dopamine, norepinephrine, and epinephrine. All of these exhibit their vasoconstrictive effects through alpha activity. So anything to the right side of the line in the middle is really going to have some sort of alpha activity, while anything in red above the line is going to have beta activity, which is really going to target your cardiac output. All of the ones in red are, of course, our catecholamines. They're all going to act on alpha or beta receptors. And while our green, vasopressin, is a standalone agent that has a unique mechanism of action, as you'll see soon, making it particularly helpful in certain shock conditions. Sorry. I'm not going to touch on dobutamine or isoproterenol, which you see on the left-hand side of the graph, as more inotropic agents. It's outside the scope and time allotted for this presentation. So looking at this chronologically, in 2008, we had the VAST trial published, which looked at, it's titled Vasopressin versus Norepinephrine. It was really vasopressin in conjunction with norepinephrine versus norepinephrine alone in septic shock. And what this group found is that while both regimens could adequately achieve MAP goal, the vasopressin group supplementing the norepinephrine did so without causing tachycardia to the degree that the norepinephrine group alone did. And they also took a subset of these patients. So vasopressin being an endogenous catecholamine, which helps maintain or auto-regulate blood pressure, we expect to be at certain levels in all normal individuals, usually around 4. And at baseline, all of these patients did have a level around 4. Once these patients then started on their pressor therapy, you see the bottom line here are those that were randomized to norepinephrine alone. And you can see, as might be expected, vasopressin levels did not change. This, what we're looking at here is what would be considered an inappropriate normal level of vasopressin. In these patients with septic shock, you would expect higher levels in response to the low perfusion state. So of course, infusing vasopressin then helps us reach supraphysiologic levels of vasopressin, but with a rapid decline immediately after cessation, which you see with the patients in the white squares. So this is helping us reach what might be considered normal in the state of septic shock levels. Now, this study did not show any mortality benefit in vasopressin versus norepinephrine. However, you can see a clear trend between the two lines, and that the vasopressin group had a higher probability of survival, although not statistically significant. They did also look at patients who were considered to have less severe septic shock versus more severe septic shock, defined by the norepinephrine dose at randomization. And it was actually found that those patients with the less severe septic shock, norepinephrine doses of 5 to 14 mics per minute, actually did have a mortality benefit as opposed to the patients with more severe septic shock. So perhaps an earlier role for vasopressin in these patients who have not yet decompensated too far. A lot of the way that we choose our vasopressors is not just based on their efficacy, but based on their adverse effects. So it's important in all of these trials to consider what the trade-off is in the regimen that we're choosing. I just want to bring your attention to two of the adverse effects seen in the VAST trial, where the norepinephrine group had a higher rate, although not statistically significant, of cardiac arrest, and the vasopressin group had a higher rate of digital ischemia, as we see commonly with these medications. So again, tailoring based on the patient's conditions and what we're seeing and reevaluating constantly is important. So also in 2008, we had a trial that compared norepinephrine versus epinephrine in patients who were critically ill. Now, this was not strictly patients with septic shock. And they too found that epinephrine is a perfectly good vasopressor. It could achieve MAP goals, but at the expense of tachycardia, more arrhythmias, particularly in the early phase of infusion. They also found that due to some of the metabolic effects that epinephrine has, it results in, it's not necessarily a lactate production, it's actually just a decrease in lactate clearance. So we've talked earlier today about lactate as a critical marker of adequate perfusion in these patients. So it's important to consider that in patients on epinephrine, this lactate clearance may be reduced, and it limits the reliability of lactate as a marker of perfusion. Also, due to the metabolic effects, we see the higher insulin dose due to increased glycolysis induced by epinephrine. So blood sugar we haven't barely even touched on today, but also a critical thing in our ICU patients. Lastly, in 2010, we really got down to the debate of dopamine versus norepinephrine in the treatment of shock, and they looked at all different types of shock in this trial titled SOAP-2. And these patients were these patients with any type of shock, also looking at mortality as a primary outcome, there was not found to be any statistically significant difference, although as you can see in the norepinephrine group, across the board there was a trend towards a lower mortality. So not quite exactly the clarity that we wanted, but they did, as I talked about the balance of adverse effects versus efficacy, there was consistently higher rates of arrhythmias, both atrial and ventricular, in patients in the dopamine group throughout the study compared with norepinephrine. When they did a subgroup analysis of the types of shock, it became clear that in patients with cardiogenic shock, that dopamine was associated with worse outcomes, higher mortality, and therefore in that particular subset, certainly dopamine would not be the drug of choice. Since then, we've had many meta-analyses published based on smaller trials that perhaps did not show a difference in themselves due to the population size. However, multiple meta-analyses have shown what SOAP-2 indicated there was a trend towards, which was a decreased mortality when using norepinephrine in septic shock compared with dopamine. And similarly, a consistent trend with adverse effects and cardiac arrhythmias when comparing the two medications. So going back to our patient case, your patient was volume resuscitated, although you can see in red he remains hypotensive with a MAP of 55. He has a heart rate of 140 and AFib. We are treating empirically with antibiotics. He's continuing on fluid replacement, fentanyl for comfort, DVT prophylaxis, stress ulcer prophylaxis, and he is currently on a norepinephrine dose of 14 mics per minute. So at this point, what subsequent intervention may offer the maximum benefit for this patient? I think we have all learned today that in this particular patient, likely vasopressin, due to the current septic shock refractory to a single vasopressor, and vasopressin at a low dose may be the optimal thing to improve perfusion in this patient. So in summary, our current guidelines recommend a MAP goal of at least 65, norepinephrine as the first choice of vasopressor, and this is really the first time that the guidelines have been that specific and narrowed it down to that degree, but also allowing epinephrine and dopamine in certain unique patient circumstances. But I do want to mention a very likely future direction that we're going. Currently under FDA review is this medication angiotensin II from the Athos 3 trial, something that we participated in. Angiotensin II is obviously an enzyme very much involved with autoregulation of blood pressure, renal perfusion, and so these investigators have turned this into a continuous infusion used for patients with septic shock. Their primary endpoint in the study, unfortunately, was not mortality. It was MAP response at 3 hours, but you can see from this table that over 70% of patients reached a MAP goal, which was either actually 75 or an increase of 10, much more frequently than the patients who received placebo, and this is in addition to standard of care vasopressors. They did show a improvement in SOFA scores at 48 hours and also a trend towards a decrease in mortality, although this trial only had 321 patients, so perhaps a larger trial would add more clarity there. So in summary, we are making headway. We have very old drugs with new data coming out regularly. Some of our more common vasopressors are falling out of favor, such as dopamine, and we're really seeking new therapies because with our catecholamine use, adding more and more catecholamines is not necessarily going to get us to where we need to be without adding toxicities that are intolerable. But again, early recognition and intervention are critical in these patients.
And taken all the time out of your most important work. One of the things we have been meeting for every 2 weeks, in the beginning every week after we ended the sprint, and we call our group Sepsis Saving Lives Through Collaboration. So I thought it was appropriate for for this session. I do not have anything to claim, and what I'm going to do very quickly so that we have time for questions is to review the importance of an interdisciplinary team approach to sepsis management, examine the theory of relational coordination, but I'll make it really short, to enhance team collaboration, and then analyze some sepsis outcome and bundle compliance data. And actually, I'm really just going to show you that we consistently share the data very timely every month with the group so that we're constantly moving forward. So just looking at what we needed to do to make this happen, and I'll tell you, Dr. Holt's leadership was just incredible, collaborative, nurses working with physicians. It's the way we get things done. There's nothing like it, and it was a great, great experience. So really, it was very important that we involved informatics, the physicians, the quality group, the pharmacists, the nurses, and then around that was the analytics, the navigator, the respiratory, the rapid response team, the EICU, and leadership as a whole. Relational coordination, I know folks get nervous when you talk about theory, but what I like about this theory is it's really simplistic, and it's to the question that was asked, what do we do for folks that don't want to move forward with this, and how do we communicate? Relational coordination looks at the way we interact with our peers on every level, treating people with mutual respect, having shared knowledge and shared goals. When we're all interacting on a professional manner, we're able to get so much more done for our patients. And that's really what is the basis of this theory. And it really originated in airports, the importance of directing the planes and making sure that things are kept safe. And then the theorists really moved this into the clinical area. And I think it's so important. I've been a nurse for 30 years, and I've had some great physicians and nurses that I've worked with, and the collaboration between us made all the difference in the way that we treated our patients. And then connecting the care, we really took groups of experts and brought them all together. There were folks with information about sepsis and expertise, and we integrated that into the team. Situational awareness, being aware of what's happening on the ground. Folks like John, the first sepsis navigator, who is constantly there out on the floors, helping the nurses, helping the physicians understand what it is we're trying to do for the patient, and working through, okay, this happened this way, but how can we make it better the next time? Intervention, getting that early intervention, we all know, and we've seen in many of the talks today, that this is key to saving patients' lives. And then the assessment of our patients very early. One of the things we've worked very, very hard to do is to make sure those assessments are done first thing in the morning so that when the physician comes through, we've already got information that they need in order to begin to treat the patient. And in the center, one of the things that's a common thread throughout all of this is using the tele-ICU. Some folks call it EICU. Nationally, it's called tele-ICU. And that's new. In Virginia, we're the only hospitals that are using the tele-ICU for this purpose. Out in California, they've been doing it for a while, and in Illinois, they've been doing it for a few years. It's a way to be able to connect the care and to use our resources along with the rapid response team, along with the navigators in the hospital, to be able to answer the questions for the nurses real time, help to coach them, be sure that the care is escalated, and connect them with the physicians when it's appropriate. And we've even had, there's a OB physician at Fair Oaks who calls our nurses to ask our advice when she begins to take care of a septic patient. And so we're really excited about that. What is the tele-ICU? I know a lot of you may know. Anyone in critical care usually does know. We have a nurse, a critical care nurse on the other side of the camera who has that clinical expertise. They have at least 5 years. Most of our nurses have 20 to 30 years of experience. And they're able to answer your questions no matter where you are in the hospital. If you're in the ICU, if you're out on the floors, just give them a call. They're there to help you. Even if you think it's not necessary, if you have a question you're not sure of, just call them and they'll work through it with you. And they'll even follow up with you as the day goes on and find out how things went, which I think a lot of nurses have been very, very grateful for. Now, when we are covering close to 2,000 beds to support for sepsis. In the EICU world that we normally live in, we cover 70 ICU patient beds. So we have two different roles, and we've also added ECMO, and we also support disaster efforts. So call them. What we have seen, I think I have a slide on this, but the numbers are not accurate. We've seen close to 1,500 calls since January. What do we do when they call? It's a chart review because we can see Epic all through the system. So our nurse jumps in and they start doing a chart review along with the nurse or the physician or whoever needs our assistant. They may mentor a nurse and help them know what to bring to the doc. What kind of information do you need to have? And then that escalation of care. The changes in the EHR, I can't say how important this was. This team was outstanding, and Joanne was my best friend through this because, what we did was we took nurses and docs, put our brains together, what we thought that we needed to do, and then we took that informatics piece, and they knew how to make it happen, and so we pulled it together. And there were a lot of really early mornings that we talked and talked and talked about this, changed it again, and Joanne was so flexible. So we did add an RN flow sheet, an index report. So we did teach a lot of nurses how to go in and find that system list that Dr. Holt was talking about that will pull up any of your positive SIRS 2 or greater that'll come up on a system list in your unit. So if you're the charge nurse or a sepsis champion, you could pull up this list every day and look and see who are the patients I really need to be looking at, who are the ones that need help right now, and who are the ones I need to keep an eye on all through the day. There were OB and trauma considerations so that we were sure not to cause a big situation for them by looking at their patients really early. Like the OB patients tend to have a high WBC even before they're in labor. And so that was something new to me. I didn't know that. And that system list is what I also talked about. And then the clinical overview reports. There are reports you can pull up to see, are all my nurses documenting by 9 a.m. so that you can see the compliance in your unit. And I can tell you, John Lawrence at Mount Vernon has done great work on this in that he's seen higher and higher compliance, because what he does is he looks at these numbers, then he goes into the unit, says, hey, you're at 96%, but that unit's at 99%. So then he gets the other unit up to 99%. So it's like a competition to get the charting done, and that's been really helpful. For education, we had didactics. We had greater than 85% of RNs, but what was really exciting, we also included the clin tech, because you got to think about it, the clin tech's doing the vital signs. they may see something and it might not come to your attention. Hi, Sarah. And so we included them in the education, and you know what? They all did it. They really, really jumped in and did it really fast. Champions, we still need more champions. Having a navigator in every hospital is very, very important. We're not there yet, but we are certainly bringing it out there, bringing it up in any opportunity that we have. That's a very important role. And then the sim lab, we are still working on education creating in the sim lab so that we're doing some real-time learning in the lab. We discussed the barriers. So when we meet every 2 weeks, like I said, we started every week and then we moved it back to every 2. And so we talk about barriers, and then we also talk about successes, and all the folks that come are sharing across the system. We do a monthly data review. We look at the data, we bring it out, we talk about, oh, what do we think was happening over here? A lot of what we talk about with the blood cultures is maybe the culture, the specimen bottles aren't there, or maybe there's someone else drawing the blood, so things aren't happening fast enough. So we share ideas, we recognize wins, we share best practices, and we do a system review of progress. The Sepsis Navigator, again, I can't say enough. They do clinical expertise, attention to detail. They collect and analyze the data. They need to have an ability to lead and influence others, accountability and recognition. And we have just written a job description, and we're just waiting for that to be finalized, and then that'll be out there for folks. The outcome drivers, screening within 2 hours, documentation compliance, the physician order set utilization, the lactic blood culture, antibiotics and fluid, and those bundles, whether or not we're meeting them 3 hours and 6 hours. This just takes a look at a chart that we will share every 2 weeks and look to see what are our barriers. Again, the larger outcome measures that Dr. Holt showed this morning was the sepsis length of stay, mortality, and sepsis readmission. These are my little ones. They're my little grandchildren, and you see the little fourth one in the middle that some people miss. So this is what it's all about. It's saving lives. And I can't say enough about what I've seen over my years and the patients that I think I could have done better, because if I had realized those antibiotics, like I would have fought harder for the line and made sure those things happen. But it's all about lives and people that we meet. So